Still I read, Ashok sir, I read every day for 1 hour in the evening,
Yes.
every day without fail.
You are lucky that you have to concentrate on ultrasound only. We are generalists. We can't avoid clinical.
Purana sir, you have told na the day you stop learning, it is the end. So just I want to add one line. What my husband always says: when you think that you know more than your teacher, that day your learning ends.
Correct.
When you think yourself that you know more than your teacher, your learning process ends there. Because to get to that stage, your teacher must have put so many effort, and you are nowhere to judge your teacher. That's what he always says.
Perfectly correct.
So you all have teachers. So
We
kabhi
all are
kabhi bhi lagta hai ki I know. Then I again revert back myself. No, I cannot know better more than my teacher. Always I am a student. Let me be a student. That's all.
I wait every night for Dr. Hasmukh Lal's slides to come on the WhatsApp group.
कितना
Yes,
पढ़ रहे
much
हो?
to learn from
कितना
them.
सारा पढ़ रहे हैं?
And if I don't see them there, then I'm not able to sleep.
आप तो 3 बजे तक रहते हो. I thank you.
आज को 3 बजे का 4 बजे कर दिया.
So we have 2 minutes more when Professor Khurana will start his introductory. Already 69% have participated.
Actually, all the poll questions, that is the cream of the lectures, actually. So everybody should try and attempt that.
Because they'll find the answers in the presentations, and
Yes, it is there.
you retain much longer whatever you have learned.
Right.
So it's 3:30 now. Yes, again, our gratitude to MD, NHM, and Director Family Welfare, and our team leader, and of course our Professor Khurana, Hashmukh sir, and all the trainers who have gladly extended their knowledge with our specialists right at the grassroots, some of whom have not even touched the transducers, have not held the transducers. They're all very, very happy. A lot of feedback is coming in. And so today's topic is, we have got 2 topics. It is actually from 10 to 14 weeks. The vascular study, the blood vessels were not dealt with by Shweta madam. It would have been a much longer presentation. So today we have focused on the blood vessels that we have to study, the blood flow that we have to do in between 10 to 14 weeks, which is vital to fetal-maternal health. And we want Professor Khurana to speak about that, as well as the importance of imaging the cervix in in second trimester for preventing preterm births, which is a big neonatal killer, preterm labor. So I would straight away ask Professor Khurana, whose presence is so precious for all of us. It's really a miracle that our FRUs should get to listen to him. So I'm sure all of you are very, very happy for this. Professor Khurana, can you start on today's topic, the importance of both of them?
Certainly. Thank you very much. Thank you very much, Dr. Shama Kunungu. You are always so kind in your introduction. And I find it tremendously inspiring to always be on this particular program. It's out of all the capacity building programs that I've ever seen in the world, I find that this is truly the most successful one. It's got a grassroots basis. It's got a wide audience. It's got a perfect faculty and a perfect coordination. And I have always had my doubts until a few years ago on what was going to be the advantage of a virtual versus an on-site. But I think COVID has taught us that yes, indeed, we can make a tremendous use of this program to reach out as much as possible. I'm so glad that all the specialists who are working in the FRUs are acquiring this. And today's talks are going to be no less a golden treasure for all of us. We have the first topic, which is blood flow studies, and we kept this as a separate topic to make sure that we do justice both to the basic scan at 11 to 14 weeks, plus the blood flow studies at this time. And as you will learn from Dr. Jyotsna Rani Panigrahi, that we have a long list to go through. Some of it is a basic protocol, as she will highlight, that you should try and do this. And that particularly refers to the preeclampsia screening, because it is one of the biggest killers ever. We know that by the time this session will be over, we would have lost 5 women to preeclampsia and its complications. We also know that out of the so many thousands and thousands of births that happen every year, this is one of the biggest killers of children, apart from preterm delivery. And therefore, I truly look forward to this. She's also going to guide us through how we look at other markers for aneuploidies and some of those for anatomy. When we're doing that scan, you will understand that there is plenty of time while we're waiting for an ideal fetal position to actually do a much more extensive study of the kind that she's going to tell us about. Sometimes we wonder whether it is too much of a protocol and where do we stop? And how much should be part of standard protocol and how much should be part of an enhanced protocol. But when you start doing the scan at 11 to 14 weeks, we suddenly realize that here is a situation where you can do so much while the patient is on the table that does not take the additional effort. What you will also learn is how you can optimize Doppler for this time. And that is extremely important, because for the results to be reliable, you have to know how to have the machine settings right. You have to know how to have the Doppler position, the gate positioning correct, etc. And you can look forward to this. I've heard Dr. Jyotsna Rani Panigrahi several times, because she's so much a part of our Society of Fetal Medicine family and has been both at the center as well as within Odisha, and currently is the head of our regional chapter in Odisha. So it's really part of a family meeting as far as I'm concerned. And I really look forward to that talk. So please keep your eyes and ears open. It's going to be a treasure trove, and it's going to be a very, very important way of improving perinatal outcomes with each one of your patients if you do it ideally. The second topic is even more close to my heart, the cervical assessment, because we do understand that preterm deliveries are the biggest single killer of neonates in the whole world. Yes, part of this is iatrogenic because of a high-risk pregnancy, but part of it, especially the very premature ones, are because of problems with the cervix. And although we still don't have a perfect treatment for this condition as yet, we do understand that the very fact that you're able to stratify patients is going to be able to save almost half of them, which really is fantastic, because this means that 1 out of every 2 patients that is going to feel bereaved if they were to lose their pregnancy is not going to feel bereaved, which is a fantastic amount of progress for a condition we understand so little of. And that will be our second talk. So these two talks are going to save millions of lives over the next few years because of the fact that all of you are handling the FRU are using the whole process.
One, please.
So I truly look forward to this, and I truly look forward to listening to the faculty we have today.
Thank
So
you, sir.
over to the organizers again for introducing
Thank
us.
you. Now we start with Dr. Josna Rani
Should I-
Panigrai's
Should I
talk.
share my screen?
Before you, yes, you can share your screen while I introduce you to our
Okay.
specialists and sonologists.
Is it visible?
Well, Josna Madam, Josna Panigrai is
Is it visible? Can you please tell me?
zeal for
Yeah.
Is it visible, sir?
Yes.
knowledge and
Full screen,
capability is
Yeah, madam, visible.
But go
he
to
is
full screen.
Just
he is a fellow
full screen visible.
No.
and
Uh,
she has
we
done
want
her
full
advanced
screen.
OB/GYN
Full screen visible?
training.
Visible.
Yes. Am I
NHL
audible?
Yeah,
Ahmedabad.
yeah, you are
audible.
audible. You are
Okay.
audible and your slides are moving too.
Okay. So.
Wait, I'm introducing you just now. Oh, anybody can read this. Very good.
No,
So,
I don't need, madam. Just you
No, no.
tell my name, that's all. I don't need it.
I want all of you to see how much it can take you and where it can take you. And she has been elected to the central executive of the Society for Fetal Medicine, which by which she will be useful to all of us and to the whole of the country, and take fetal medicine forward under the stewardship of none other than Professor Khurana. So Josna, the stage is yours.
Yes.
We will learn from you now of
Yes,
very
madam.
important aspect of learning, which can be taken up, and it is taken as a basic capability which all of us at the FRUs must pick up. It will be exciting to you to see how you can prevent maternal and perinatal mortality by this. Josna,
Okay.
please.
Thank you, madam. Thank you so much for the nice introduction. Whatever my introduction is, I am your student, but that's all. And thing is next, I'm going to start. Respected Dr. Khurana sir, Shama madam, Hasmukh sir, and Dr. Muralidhar Padi sir, and all my seniors and colleagues. 1 minute. Chat क्यों आ गया बीच में? Okay. Poll end करूँ? नहीं. हाँ. So my topic of discussion, after you people have listened already about the first trimester screening, I have been assigned to say the only about the first trimester blood flow, particularly the vessels, what you should scan. Okay. Next slide. 1 minute. Is it moving? Is it moving?
You'll have to click anywhere on the screen.
I have to click? Yes.
On the screen itself. And
Okay.
it should work.
Yes. Is it there? Yes. So,
Yes.
the points to cover is why it is required, what to study, know the basics, how to study it, what to interpret, and then the take-home message. First, we are using Doppler throughout the pregnancy, but I am going to highlight only on the first trimester Doppler, particularly two vessels. Today's discussion. Why you should do in first trimester? First, we are using for prediction of risk as a marker of aneuploidy in screening. Remember, it is screening as well in high risk pregnancy. And second is the prediction of maternal pathology. That is again a screening for preeclampsia, pregnancy-induced hypertension. And third is we are using detection of some fetal anatomy, applying our Dopplers like for the aneuploidy screening, we are using ductus venosus, tricuspid blood flow, and aberrant right subclavian artery is also taken into consideration, but that is not under basics. And for the maternal screening of preeclampsia toxemia, as Dr. Khurana sir has told, this is the killer disease, we have to screen the uterine artery. And for the fetal anatomy, as usual, you must already know that cardiac screening without Doppler is nowadays not mandatory, is not is required almost, and a few abnormalities, and the cord insertion site, 3 vessels cord, and by that we can detect single umbilical artery, which is again has a high association with aneuploidy, and we can know the renal agenesis by detecting renal artery, and so many others. That is a vast list. And second, third trimester, I am not going to detail. These are the lists mentioned. Next, before going to the Doppler, everyone should know what is the vessels concerned. There is a side, one is fetal side and the other is a maternal side, that everyone knows. So in the fetal side, there are so many vessels. One is the umbilical artery, middle cerebral artery, ductus venous, and the list goes down. For us, the importance is the ductus venosus, and apparent ARSA, again, it is not of that important. Ductus venosus is the main vessel we screen in the first trimester. Before that, and on the maternal side, there is only artery, which is uterine artery. And umbilical artery is required in the second trimester. It is not of that importance in the first trimester. So here, you know, uterine artery are always a spiral artery. You see, this is the spiral artery. And as the gestation advances, due to the demand of the blood flow, demand and supply, all these vessels, they dilate and they become less curved, so that they can the trophoblast will invade to the endothelial layer of the vessels, and there will be easy of the circulation in between. When this process hampers, there is decreased blood flow, increased resistance, which causes high PI level, that I will go in later. Next, uterine artery is here. I am highlighting uterine artery Doppler reflects trophoblastic invasion. This is the trophoblastic invasion. Now, before going to the Doppler studies, you should know the basic minimum that must be already taught by Doppler setting. I am just going to brief about it. You should know what is your machine. There are only 5 switches you have to operate. Out of that, one is sample gate, pulse repetition frequency. You see, there is a button PRF, and this is the color button you have to on. This is the 2D, everyone knows it, and color button, pulse wave Doppler, M mode. These are not required. You have to note the P wave and color Doppler, PRF, and the sample gate. High pass filter, this is a filter, wall motion filter. This sometimes it works. And everyone should know standard setting is the color coding is the velocities away from the transducer is blue, velocity towards the transducer is red, because we have set like this. Upper is red and the lower is blue. We can change it for a standardized protocol. It is always red is up and blue is down. And when you see mixed color, that is known as aliasing. It is bright blue or bright yellow. So this is the color coding. Once you know the color coding, you see the sidebar of your machine. It is set. Then you another important is the insonation angle. What is insonation angle? Here, this is the abdomen of the mother, and the beam is coming like this, and the vessel is like this. So there is an angle between the ultrasound beam and the vessel. This beam should be less than 30 degrees. That means the vessel should be very nearer to the vertical line. Remember, you set your transducer and color setting like this, that this should be as nearer as to the vertical line. One basic principle is that in the 2D scan, our ray should be perpendicular. Ray should be perpendicular. It should be like this. Suppose we are focusing a femur. Femur should be like this. Short the reverse, and as much close to the vertical line you are, the more the sample volume is. You see, here the vessel is nearer to the vertical line. You see the sample is so beautiful, but when it goes away, you see the sample is so less. Now, another is pulse repetition frequency. What is pulse repetition frequency? That I will explain later. Just to see, when you decrease the frequency, we see so many vessels. So for that, we have to increase the frequency. So to prevent the aliasing, this is aliasing. You see multiple color. Here, once you start increasing the PRF, there is the screen is cool, and you just focus to what vessel you want to do. That is pulse repetition frequency or PRF button. Here you can adjust that. When you see a vein is a low PRF. So you have to set your machine is a low setup so that it will pick up the veins. If you keep your PRF high, it will not pick up the venous flow. So that's why in doctor's venous, your setting is like a venous flow, not the artery. In uterine artery, you have to increase the PRF to detect the arterial flow. The next is Doppler. Always take the sample get across the vessel and increase the PRF to control the aliasing. Sometimes you may see that there are two waveforms. That case, you have to decrease the low the baseline or you have to increase the PRF. And other is the sweep speed. Why the sweep speed is important? Why I'm saying you all these things will come under while taking the Doppler of the doctor's venous. And you should understand what I'm saying. This is the sweep speed. Sweep speed means you have to increase or decrease. Once there is, you will sweep speed will be less. All the waveforms are well delineated. Here you see the sweep speed is okay. Here the sweep speed is less on the right side. Next, pulsatility index is always the downstream impedance. Means what we are sampling. Suppose we are sampling doctor's venous. Where doctor's venous goes? Doctor's venous goes and enter to the right atrium. So what is the downstream of doctor's venous? It is the right atrium. What is the downstream of right atrium? It is the right ventricle. So indirectly, we are assessing right ventricle, right atrium, which is reflected in doctor's venosus. So pulsatility is always the downstream impedance. We are assessing the pulsatility index of uterine artery. Where uterine artery goes? It goes to the placenta. So it indicates the resistance or impedance given by the placenta. That is a basic thing you should understand. When you, whatever vessel you calculate or measure, this should be in your mind. I am calculating or want to know the impedance given by the downstream thing. Now, next slide. Yes. I think, yes. So uterine artery doctor, there are two techniques. One is transabdominal and the other is transvaginal. In the first trimester, you can use both. A transvaginal is a better if the patient permits, and you should counsel the patient prior to the transvaginal technique. Transabdominally, the probe is placed longitudinally. Remember, the probe is placed longitudinally in the lower lateral quadrant of the abdomen and angle medially. Angle medially. If you angle laterally, you will see the fetus. If you angle medially, you can see the uterine vessel or iliac vessel or what is of the mother's pelvis. Color floor mapping is used to identify the uterine artery as it appears in the external iliac artery. You see, this is the external iliac artery. I am just going to the steps. This one is the uterine artery. And if sample volume should be placed 1 centimeter downstream the uterine artery. Downstream. Actually, uterine artery is a branch of internal iliac artery, but here it appears to these two external iliac artery crosses in the ultrasound picture. This is the uterine artery and this is the external iliac artery. This is the crossing point. You should take 1 centimeter away from the crossing point. And another thing, here you see, here the uterine artery goes and bifurcates. So if it bifurcates earlier, then no need to stick to the point that it is not 1 centimeter. I cannot take that. Always remember that your cursor should be put in the line of before bifurcation. Remember, before branching, before bifurcation, to take the accurate uterine artery measurement. Just this is the procedure. First steps to measure transducer longitudinally. I'm repeating this because you people have to remember it. Move laterally to the iliac fossa. Here we see, once you move, you see two major vessels. One is vein, one is artery. Then again, you just move. You see one vessel is crossing. This is the identified two big vessel, one artery, one vein. Look for crossover of a vessel, that is uterine artery. Now you zoom the image. always zooming and focus. These are the two buttons you should play always. Don't afraid. Zoom the image. Then you adjust take the sample gate. Take the sample. And again, I am repeating, this is the beam, this is the angle. You should adjust the angle and go nearer and switch the bottom set. You can measure it by auto bottom, or you can measure by manual tracing. This is the video. Again, once you do this, you can go also transvaginally. This is a ISOG slide. Everything is available in the website. You can go and get it, find that how to, and go this, you can go to this slide. I've already told. See the machine setting. The color Doppler velocity on the right side bar, red and blue, it should be 30 to 40 cm, and pulse wave and Doppler velocity should be 80 to 100, and filter should be low, and the sample should be 2 mm. These are the criteria you should meet. And how you do? Go transvaginally, identify, obtain a mid-sagittal section of the uterus and cervix, then zoom it, then apply color flow. You see, this is just like hook, like a U. Slide the transducer from the midline to the paracervical area. Gently move the transducer from one side to the other side. First, you move there only. You saw a big vessel with aliasing. Uterine artery itself says that I am uterine artery, just pick me up, because there is no such vessel with this structure and this much aliasing, and nearer to the cervical house. Sorry. Set the sample gate again 2 mm. Angle of isolation where I have told, this is the main line, this is the vertical line, and this is close to it. Angle of isolation 30 degree. Peak systolic velocity should be more than 60 centimeter in the uterine artery. I am again highlighting it. Less than 60 is not the uterine artery. It may be something, either branch or some other thing. Uterine artery PI is usually more, velocity is usually more than 80 to 100. So mean PI is obtained. This is the vessel, this is the tracing. So what is, there are 3 S and D. This is the peak of systolic, and this is the end of diastolic. And we are calculating the PI value. What is PI? Pulsatility index. That is the peak systolic minus end diastolic divided by mean velocity. And this is known as PI for all the vessels to come. Usually you are measuring PI values. In the Doppler study, you will go detail into what is PI and all these things. But PI value, except the PSB, we are measuring for the of the MCA in RH isoemination to know the fetal anemia. Otherwise, usually you are measuring the PI. Another important thing, in all the reports you must be seeing there is notch, and all are worried why there is notch, there is some problem. No, notch is a normal finding in 11 to 14 week, around 50% cases. And this is the chart, and there is a chart here. It is also available in the website, and usually 2.5 we are taking as a cutoff in the first trimester. And as the gestation advances, gradually the fetus demand more blood, and you see there in this, as the gestation advances, this is the so high PI value. Gradually it decreases in the second trimester and late time and the third trimester. The diastolic flow increases, so the PI gradually comes low. See, here you see, here the velocity should be 80 to 100. In case this, here the velocity is more, here you see, the PI is 2.86. Here the PI is 1.811. So in this case, the PI is high. When you find a high PI, there is suspicion of developing PIH, and we have to supplement with ecosporin 150, not 75. Again, I am repeating, it is 150. And what are the fallacies over here? Uterine artery, you may take iliac artery. Iliac artery tracing is such a high PI, and the wave pattern is different. Suppose you are taking at the crossover point, you see, there is a mixture. This is the internal iliac artery, this is the uterine artery. So you can get a mixed waveform. Another is when you take at the level of branching, suppose you are taking you have to take before branching. If you take after branching, then the velocity will be low. You see, there is low velocity. And another remote possibility, there is a vesical artery, you may think, but the wave pattern is different. It is far away from the uterine artery. These things also you have to keep in mind. So why are you screening? We are screening uterine artery PI to predict the preeclampsia or pregnancy-induced hypertension. Here is the nice guideline. And when you take only maternal age factor, the detection rate is this one. Maternal factor plus mean arterial pressure plus PAPE, detection rate is 52.8. When you add uterine artery PI, the detection rate increases to 76.1. You just imagine the difference of 20% increase. When you add PLGF, it will further increase to 81.7. PLGF is not possible for all patients of our setup. At least we can do this much, because we are sending double marker to almost all. Nowadays, everyone is sending. You can do this at least, or else you can do this. This one should practice in Odisha. It is very easy. It is not a difficult job. And this is available in the Fetal Medicine Foundation website. This is also a free website. Go to the risk calculation chapter here, prediction of risk of preeclampsia. Go on putting it is asked to put, and you can screen and find out the possibility of pregnancy, preeclampsia risk at 32 weeks, again at 40 weeks. Recently, I got a patient whose blood pressure is 186 by 90, I think. When I found the risk to be 1 in 7 in the term. So you can do it. This is not a big job. You can take the measurement, sit in the home, put it in your own laptop and calculate. Once you start habit, just do one case per day. That you can do. It is not at all a tough job. Now let us come to the other vessel, that is ductus venosus. That is actually, for me, it's a vessel of choice. So ductus venosus, what is ductus venosus? Ductus venosus is a narrow trumpet-shaped vessel which is seen in the fetal liver. This is the ductus venous. You see, this is the ductus venous. This is the ductus venous. Ductus venous connects what? When the umbilical vein turns to portal vein, umbilical vein turns to portal vein, one small vessel bypasses the liver and go and directly join to the confluence of IVC. So here, one vessel go and directly join to the IVC. This is known as ductus venosus. Why the God has created like this? Because the fetus need a higher oxygen saturation for the upper limb. So here you see, the flow is like this. When this is the IVC and this is the ductus. You see, there are two streams here, two streams. The blood which is coming from the IVC goes to the right atrium directly. That is Y-shaped crossing. But the blood which goes through the ductus venosus, it directly goes as a jet, because suddenly there is decrease in lumen. So the velocity, you know, when the diameter is less, the resistance is more, the velocity flow is more. So with high velocity, this is going, and as a jet goes to the directly through the foramen ovale to the left atrium, to the left ventricle and the upper brain, upper extremity. Such a beautiful creation God has created and given us the opportunity to know whether it is good or not. This one, I love this slide. And this is the IVC. So you must understand the anatomy of, this is the ductus venosus. You must understand the anatomy of ductus venosus. Go to the fetal circulation, please, and have a look and read personally what is fetal circulation. Unless you read it, you cannot know what is ductus. Unless you know what is the ductus, from where it starts and from where it ends, you cannot focus it. See, so in the first trimester ductus, what are the things? You see, this is the heart, this is the vessel coming, and here is the maximum arising, that is the ductus venosus. It go and ends directly to the IVC. See, and again I am saying here, you see the position of the vessel, it is so nearer to the vertical line. The more nearer it is to the vertical line, the more better the waveform. You see, so the gestational, what are the criteria? The Fetal Medicine Foundation as well as ISOG has put few criteria for the ductus venosus. First is the gestational age. You must be knowing that 11 to 13 week plus 6 days, and the magnification should be such so that the thorax occupies almost all whole screen. Right ventral aspect of the baby. Color mapping, you should see the heart, you should see the ductus venous, and you should see the umbilical vein. These three things you should see. Should be in your screen. Then gate should be, this is the gate. These two equal sign. This is the gate. Gate should be 0.5 to 1. Why you are putting it so low? Because ductus venous is such a small vessel. If we are increasing the gate, unnecessarily you will go to take the measurement of all other vessels mixed with the ductus. So remember the vessel size. Whenever you are putting gate on any of the vessel, remember the vessel size and adjust the gate accordingly. Here is the ductus is very narrow vessel. The gate should be adjusted to low, that is 0.5 to 1. And no filter, wall filter here I have highlighted. The PRF should be, this is the PRF should be 7, and the wall filter should be here WMF. In your machine setting, you will see wall motion filter. This should be 50 to 70. This is the, you see, wall motion filter is 50 to 70. Gate is 0.5 to 1 millimeter. But in uterine, remember, gate was 2 millimeter because the vessel is more big. And sweep speed should be 2 to 3. So that all waveforms should be delineated clearly. For arrhythmia, we are making it more speed. But for this, sweep would be slow. See, again, I am repeating this.
Madam, sorry to interrupt. Madam, actually, PPT गुड़ा का hazy होचे, slides का hazy होचे.
Hazy होची?
आगे madam.
Josna madam, आपनकर internet ठीक अछि नि speed? Internet speed is okay?
सुबुनी की दिसुनी?
Madam, आपन voice clear अछि, but PPTs are hazy.
केबे ठुजी हेलानी? एबे ना हेलानी केतो?
हेलानी actually हेलानी 3-4 slide एमती hazy दिसला. So
टिके मु नेट चेक कर देबी? मुझे चेक करके माँ वो नेट लगोची देखियो.
Madam, it is visible. It's visible.
Sambit, share the slides. No, nahi. It is कितना number slide? Can it be shared from the host? Sambit?
Yes, madam. है परिवा. आगे madam.
Your slide will be better.
Madam, मुझे कुछ
Can you
madam,
talk?
first I was wanting that more about the internet issue थिला, but समझते हुए message
देखी दियो मुझे अन्य देखी दियो. ठीक अछि कि नहीं देखी दियो तो चेंज करिया. अगर स्लाइड टा न देखले लाभ नहीं ना. बुलबुल.
Slide is clear, madam. Slide is visible.
No, initially it was very good. Just slight haziness of the letters.
No, madam, एबे ठीक अछि पूरा देखा जाउछि clearly.
मते तो दिसुछि मु जाननी कोन अछि. देखंतु तो.
ओ ये स्लाइड शो कर दो स्लाइड शो.
मझरे हेजी पड़े आछि.
तो करछि मैडम. मझरे
हेजी
अच्छा गोटे काम करछि मु नेक्स्ट को मोर बंद कर दोछि. मोर जो येटा को बंद कर दोछि. जस्ट लेट मी ऑफ. देखले एबे
आगे मैडम एबे टिके क्लैरिटी आसला.
अछि. तो लागुनी एबे असुविधा होतो टिके. एबे कोन ओटे एंती हलुछि आ मुझे अन्य कौन मत तो एबे असुविधा लगे.
ये जोस्ना can we ask Sambit to project?
नहीं मैडम मु करबी ना. मोर आसुछि तो भल रे आसुतिला कोन एबे नेट इश्यू जदी हेतिबो देखले मत तो आसुथिबो मैडम. एबे देखले आसुनी के
दब होछ.
एबे देखंतु आसीबो ठीक रे.
हां
आसुनी. नहीं दब होची.
slides are blinking actually. Your slides are blinking.
एबे ठीक है सर.
अभी ठीक है.
हेजी अच्छी
Hazy.
हेज अच्छी क्लैरिटी नहीं.
Better.
आगे मैडम एबे ठीक है. मैडम एबे लेटर्स गुड़ा क्लियरली रीड करियो.
ठीक अछि तो
स्लाइड शो कर दियो. स्लाइड शो फुल स्क्रीन कर दे.
स्लाइड शो करबी. एटी कोन ओटे इटा ओटे रहि जैछि मोर.
Show task bar.
फुल स्क्रीन तो इटा थिला तो इटा कोन हला मु जाननी. गोटे मिनिट मैडम. ए डिस्टरबेंस तो भारी असुविधा.
ଉପରକୁ ଗଲେ ସ୍ଲାଇଡ ଶୋ କ୍ଲିକ୍ କରୁନୁ ତଳଟା ଦେଖା ଯାଉନି।
ଏଇଟା ଯେ ମୋର ସେ ଏଇଟା କାହିଁକି ପଳେଇଛି ଉପରକୁ ତ ସେଥିପାଇଁ ମତେ କରୁଛି ମ୍ୟାଡାମ କରୁଛି।
But the talk is going marvelously. Very clear concepts.
କାହିଁକି ଯାଉନି ମୁଁ ଜାଣିନି ମ୍ୟାଡାମ। ସ୍ଲାଇଡ ଶୋ ହଉନି କାହିଁକି ମୁଁ ଦେଖେ।
Yes, I can also see two black dialog box with black screen.
କଣ ହେଲା ମୁଁ ଜାଣିନି। ମୁଁ ଗୋଟେ କାମ କରୁଛି ମୁଁ ଟିକେ ଏଣ୍ଡ କରିବି ଆଉଥରେ ଏଣ୍ଡ କରିବି।
ଆଉ ଥରେ ଲଗଇନ୍ କରନ୍ତୁ ଜ୍ୟୋତ୍ସ୍ନା ମ୍ୟାଡାମ।
ନାଇଁ ଗୋଟେ କାମ କରୁଛି ମ୍ୟାଡାମ। ସାର୍ ଏଠି କଣ ହେଇଛି କି ମୋର ଏଇଟା ପଳେଇଛି ଉପରକୁ ତ ମୁଁ ଜାଣିପାରୁନି ଏଇଟା ମୋର।
ମ୍ୟାଡାମ ଲଗଇନ୍ କରିବା ଦରକାର ନାହିଁ, ଆପଣ ଆଉ ଥରେ ସ୍କ୍ରିନ୍
ଆସିବ,
ସେୟାରିଂ ଟା
କରୁଛି।
ବନ୍ଦ କରିକି ଆଉ ଥରେ
ହେଇଗଲା,
ସେୟାର କରନ୍ତୁ। ହେଇଯିବ।
ରହିଯାନ୍ତୁ ହେଇଯିବ ଏବେ ହେଇଯିବ।
Unshare କରିକିରି ପୁଣି share କରିଦିଅ।
ମୁଁ ଏଣ୍ଡ ସ୍ଲାଇଡ ଶୋ କରୁଛି ତାପରେ ଆଉଥରେ କରିଦଉଛି ହେଇଯିବ। ଜଷ୍ଟ 1 ମିନିଟ ହେଲା ଏବେ।
Share screen ଆଉଥରେ କରିଦିଅ।
ଏବେ ଦେଖନ୍ତୁ ତ ମ୍ୟାଡାମ ଏବେ ଦେଖନ୍ତୁ
Stop sharing କରିକି ଆଉଥରେ share କରିଦଉନୁ। ଏ ପୁରା black ଆସିଗଲା ତା ଉପରେ କଣ ଗୋଟେ।
ଏବେ ହଉନି।
ବ୍ଲାକ୍ ପ୍ୟାଚ୍ ଗୋଟେ ଦେଖାଯାଉଛି ତା ଉପରେ ଉପରେ ତଳେ।
ବ୍ଲାକ୍ ଟା ତ ଦିଶୁଛି ମ୍ୟାଡାମ ସେଇଟା ମୁଁ ନେଇଯିବି। ସେଇଟା ତ ଅଛି ଗୋଟେ ସେଇଟା ବ୍ଲାକ୍ ଟା ମ୍ୟାଡାମ ଅଲଗା।
ପୁରା black ହେଇଗଲା।
ମୁଁ ସେୟାର କରୁଛି ବ୍ଲାକ୍ ଟା ନେଇଯାଉଛି ଉପରକୁ ହେଲା। ତଳକୁ ନେଇଯିବି ଉପରକୁ ନେଇଯିବି ତାକୁ ମିନିମାଇଜ କେମିତି
As
କରିବି।
Sambit said, you unshare, I mean, stop sharing and again share.
ଷ୍ଟପ୍ ସେୟାରିଂ ବ୍ଲାକ୍ ଦିଶୁଛି ମ୍ୟାଡାମ ଏବେ।
ହଁ ସେ ଉପରଟା ପୁରା ଘୋଡି ହେଇଯାଇଛି ବ୍ଲାକ୍। ଏପଟେ ଲେଟର ଗୁଡା ବି ଡାହାଣ ପଟ ସାଇଡ୍ ରେ ବ୍ଲାକ୍ ହେଇଛି। Everybody is seeing this black. Yes,
ହଁ
Tapan also.
ଦେଖାଯାଉଛି ବ୍ଲାକ୍ ଦେଖାଯାଉଛି।
ବ୍ଲାକ୍ ଟା କେମିତି ଯିବ ଗୋଟେ ମିନିଟ
ନାଇଁ
ମୁଁ
ମୁଁ
ଆଉଥରେ
କହୁଛି
ସେୟାର କରୁଛି
ମ୍ୟାଡାମ
ମ୍ୟାଡାମ।
ଆପଣ ମ୍ୟାଡାମ ଆପଣ ଯଦି ପରମିଶନ ଦେବେ ତାହେଲେ ମୁଁ ସ୍ଲାଇଡ ସେୟାର କରିଦେବି। ଆପଣ
ନାଇଁ ମୁଁ
ନେକ୍ସଟ
ମୁଁ
କହିଚାଲିବେ।
କରିଦଉଛି ମୁଁ କରୁଛି ଜମା କହିପାରିବିନି
ଆଜ୍ଞା
ମୁଁ
ମ୍ୟାଡାମ।
ସେୟାର
ଓକେ
କରିଦଉଛି।
ମ୍ୟାଡାମ।
ଆଉଥରେ ସେୟାର କରିଦଉଛି ତାକୁ ଛୋଟ କରିକି ଆଉଥରେ କରିଦଉଛି। ଏ ସେଟିଂ ରେ ଟିକେ କଣ ମୋର ହେଇଯାଇଥିବ ଆଉ। ଆଜି ଏପର୍ଯ୍ୟନ୍ତ ଛୋଟ ଦିଶୁନଥିଲା।
ସେ ବ୍ଲାକ୍ ଆସୁଛି।
ଏ ବ୍ଲାକ୍ ଲାଇନ ଟା ଗୋଟେ ଆସିଯାଇଛି ନା ଏଇଟା ହେଲା ଏବେ। ନାଇଁ ଏବେ ଦେଖିଲେ ମ୍ୟାଡାମ
ନାଇଁ ସେ ବ୍ଲାକ୍ ଆସୁଛି ତ ସ୍କ୍ରିନ୍ ଟା ଉପରେ ଆଉ। Just allow Sambit to present ଏଟା କେତେ ନମ୍ବର ସ୍ଲାଇଡ୍?
ମ୍ୟାଡାମ ଏବେ ବ୍ଲାକ୍
Just
ଦିଶୁଛି।
see, let's see Sambit project
ଏବେ
କରୁଛି
ମ୍ୟାଡାମ
ଦେଖିବା।
ବ୍ଲାକ୍ ଦିଶୁଛି କି ମତେ
No,
କୁହନ୍ତୁ।
no, whenever you are finished with the slide, he will change. You order him to change, he will
ମୁଁ
change.
ଟିକେ ସ୍ଲାଇଡ୍ ଟା ପଛରେ କେତେ ଗୁଡେ ଦେଇନି ମୁଁ ଆପଣଙ୍କୁ ସେଥିପାଇଁ ମୁଁ ମନା କରୁଛି। କେତେ
Oh,
ସ୍ଲାଇଡ୍
you
ମୁଁ
have added.
ମୋର କାହିଁକି କଣ ଗୋଳମାଳ ହେଲା ମୁଁ ଜାଣିନି। ଏଇ ବ୍ଲାକ୍ ଟା କାହିଁକି ଯାଉନି।
The black ଏପଟେ
ଏବେ
side ରେ ବି
ଦେଖିଲେ
black
ମ୍ୟାଡାମ ଗଲା
ନା ଯାଇନି।
ଯାଇନି
ଏବେ ଗଲା। ଆଉ ସେ
ଗଲା
ଲେଟର ଡାହାଣ ପଟ ସାଇଡ୍ ରେ ଆଉ ଗୋଟେ black spot ଅଛି patch ଟେ।
ଆହୁରି ଗୋଟେ ବ୍ଲାକ୍ ଷ୍ଟ୍ରିପ୍ ଅଛି।
ତଳେ ସେ ଲେଟର ଗୁଡା A wave ଯୋଉ fetal ପର୍ଯ୍ୟନ୍ତ ଦେଖାଯାଉଛି। A wave corresponds to fetal, then
ମ୍ୟାଡାମ
black.
20th ନମ୍ବର ସ୍ଲାଇଡ ତ ଆପଣ ଯଦି କହିବେ ତାହେଲେ ମୁଁ ସେୟାର କରିବି।
ଆଉ କରନ୍ତୁ କିନ୍ତୁ ମୋ ଟ୍ରାଇକୋ ସ୍ପିଡ୍ ଟା ନାହିଁ ସେଥିରେ। ଠିକ ଅଛି
ମ୍ୟାଡାମ
ସେଥିରେ
ସେଇଟା
ନାହିଁ।
ବୋଧେ ମେ ବି ନେଟୱାର୍କ ଇସୁ ପାଇଁ ହଉଛି। ମୁଁ ଭାବିଲି ଯେ ମୁଁ ଟ୍ରାଭେଲ କରୁଥିଲି
ନାଇଁ
ସେତେ ବୋଧେ
ନେଟୱାର୍କ ନାହିଁ
ମୋର
ଏଇଟା ମୋର
ଏକାଟିଆ ଇସୁ
ସେଟିଂ
ହଉଛି।
ଇସୁ ପାଇଁ ଏଇଟା ମୋର ସେଟିଂ ଇସୁ
ସମସ୍ତେ
ପାଇଁ
ମେସେଜ
ହଉଛି।
କଲେ ତାହେଲେ
ସେଟିଂ ଇସୁ ପାଇଁ ହଉଛି। ଏଟା ମୋର ଗୋଟେ
Because
ସେଟିଂ
we
ରେ
are
କଣ
recording, Josna, all these proceedings are being recorded. These
ଆଚ୍ଛା
black patches will come in the recording.
ଓକେ ଓକେ ମ୍ୟାଡାମ। ତ କଣ କରିବା କାହିଁକି
Continue, madam. Continue.
Continue.
ରେକର୍ଡିଂ ହଉଛି ନାଇଁ।
Madam, it is manageable. Please continue, madam.
ଏବେ ତ ଏଇଟାକୁ କେମିତି ଗୋଟେ ଛୋଟ କରା ହୁଏ ମୁଁ ଜାଣିନି ଏଟା ଛୋଟ ହୁଏ।
Josna, madam, please continue.
ଠିକ ଅଛି ଠିକ ଅଛି।
Doesn't matter, continue.
ଓକେ
The thing is, the extra slides that you have added, please give it to me so that in the
ଠିକ
final
ଅଛି ମ୍ୟାଡାମ ଠିକ ଅଛି ପଛରେ
recordings will be available to all the learners later.
ଠିକ
I
ଅଛି
have those slides also.
okay so let us continue. Is it okay?
Continue.
Yes. So reverse ductus is seen in 4% cases of euploid fetus. Euploid means that is normal chromosomal pattern. Even if you find doctor's venous in a reverse way, then also you should not be worried. There are 4% possibility of a normal chromosomal pattern. And reverse doctors is found in chromosomal anomalies, trisomy 13, 18, 21, monosomy X, and where you find doctor's venous abnormalities like directly draining to the infravena cava. Here, like this, you see, doctors is directly draining to the IBC, and reversal flow of the A wave or high impedance. Reverse doctors is found also in cardiac defect, and it may have a poor fetal outcome, that is fetal death. 80% of reverse A wave has a normal outcome. There are few non-cardiac abnormalities like diaphragmatic hernia, thanatophoric dysplasia, and all these things. There also you can find the reverse A wave. Doctors, this is a case where there is omphalocele, holoprosencephaly, and reverse doctor's venous. So here, when I did the CVS, I found it is trisomy 13, abnormality of trisomy 13. Another important thing in doctors is that in twin pregnancy for TTS, when in the first trimester, when you find discordance in the doctor's venous pattern, there is a possibility of low, there is increased risk when there is a discordant in the blood flow of both the twins. This is a normal pattern flow and the other is a abnormal blood flow pattern. Then you may think there are few criteria where you can predict the outcome of the twin pregnancies, and doctor's venous is also taken it one of the important criteria. Now the next vessel, what we do is the protocol for tricuspid valve, that is a tricuspid regurgitation. And again the protocol are same. The gestational period must be 11 to 13 weeks, 6 days. Magnification of the image so that it will occupy the whole thorax, whole screen. The apical 4-chamber view. The apical 4-chamber view is taken. Pulse wave Doppler sample volume should be 2 to 3 millimeters and positioned across the valve, both the valves. Why across both the valve and wide gate? Because tricuspid has 3 valves. Tricuspid valve has 3 valves. So you have to cover all the 3 valves and you have to take minimum 3 recordings and trace this. This is the tricuspid flow pattern the first trimester and a normal flow. I have skipped doctor's AC. Okay. Next slide. Sorry. Yes, tricuspid regurgitation is diagnosed if the regurgitation is
Slide
at
is
least
not visible.
Slide
All
is not
the
visible.
letters in the slide are not visible.
Not visible.
No.
Better you then do. Sambit, better you do it. Why not visible? I don't know. Not visible, madam?
No, ebe visible है.
हाँ, madam.
तो मैंने slide show न करके you do like this only.
Okay, madam.
Okay, don't do slide show. Just
Okay,
go with your
Okay,
this.
okay.
Okay.
So in tricuspid valve, you know, the cursor should be on both sides of the valve in a wide gate. This one, the sample gate, and the regurgitant flow should cover minimum 60%. Minimum 60%, minimum at least half of the systole should be covered by the tricuspid jet, because, and the velocity should be more than 60 centimeters, because the nearer vessels, aortic and pulmonary, has a maximum velocity of 50 centimeters, and sweep speed should be 2 to 3 centimeters, and sample valve should be placed again on both sides of the valve. Tricuspid regurgitation is found in normal chromosomal abnormality in pattern in only 1% cases. In trisomy 21, it is 55%. Trisomy 18 and 13, it is 33%. And it is in literature, it shows that almost all major cardiac abnormalities, the tricuspid, there is a regurgitation of the tricuspid valve and the doctor's venous reversal. And tricuspid ductus venous defined by the presence of small regurgitant jet, it could be a normal finding. If you find a tricuspid regurgitation, a small jet could be a normal finding. But if it covers more than 50% of the systole, then it could be abnormal. So routine assessment of the tricuspid valve for tricuspid regurgitation is not recommended. It is recommended for pregnancy with high risk. And this is our statistics. And this is my last slide. First trimester blood flow Doppler has a major role in triaging risk of PIH, aneuploidy and cardiac defect, and TTTS. Understanding the machine setting and fetal circulation plays a major role. Practice makes a man perfect. And this is our scoring of perfection, and this you can do when we join together. Madam, just one slide of ACE wave that is missed. I think that is missed. That everyone, yes. This, can I repeat this? The tricuspid has three triphasic pattern. One
There was
is
a question. There was a question how to identify ductus venosus. The picture
yes. This is the how to identify, na? Just
in the
you see.
when you,
See? This
how does it look?
it is the place of maximum elysing. You see, this you see. This is the place of maximum elysing. It looks like this. Here you see, this is the place of maximum elysing. When you see the there is a continuous, here there is no elysing means brighter. Go through this line. The place where you see the brighter image, you put the cursor over there and put the sample, put the PW button on. When this is the ductus venosus, trace through the ductus venosus, go to the maximum brighter point and put your cursor there and click the pulse wave Doppler. Here you see. This is the point of maximum elysing, blue, yellow and blue. Here here is only blue. It's only blue. Suddenly you see there is mixed color, yellow and blue. That is the point of maximum elysing. Put that cursor there and put the pulse wave Doppler. And there is a question, how the ductus venous, I have skipped this. So ductus venous is a triphasic pattern. Triphasic pattern of wave. One is S, D, and A. S wave depicts, again, I have told, it says the impedance of the what is next to it. So what is next to ductus is the atrium. So it reflects the arterial pressure. So here you see atrium indirectly reflects the ventricular pressure. This is the S wave, which corresponds to the ventricular systole. When the ventricle contracts, the pressure in the atrium increases and it reflects in the ductus venosus. So this is the S wave. This one is the S wave, is the ventricular systole, and this one is the D wave. That is the where once the ventricle systole is over, now the ventricle is relaxing. The blood comes from the right atrium to the ventricle. That is the early phase of ventricular diastole. That is predicted as D wave. And next, once the passive filling of ventricle is complete, then the ventricle is filled by the active contraction of the atrium. That is known as A wave or due to fetal atrial contraction. We are always remember all the waveforms are positive, means it is crossing the baseline, it is there. So whenever you are finding any wave that is going below, that is known as reversal of the A wave. That is predictive of any aneuploidy or other. This is the reversal of, you see, the A wave is going below the baseline. Here the A wave is above the baseline. These things are important. Sorry for my slides. Again, thank you so much.
Thank you very much, Dr. Paningrai. Despite all the disturbances in the slide, it was a marvelous presentation.
I don't know why this time this disturbance, I don't know. Suppose I think my computer setting has to be changed again.
You said you had given some extra slides in your presentation.
Yes.
Please share it with us.
I will upload, madam. I'm really sorry for this disturbance. I don't know why.
Yes, I think we'll keep the questions to the last. Shall we ask Dr. Abhay Patnaik to start his presentation?
Yes, madam. I'm stop sharing. And stop sharing.
And at the end of it, we'll have the questions and answers, and Professor Khurana and Dr. Hashmukla will join. Stop sharing. Abhay will start.
Yes. I'm sorry for the disturbance, but I think somewhat I'm audible or visible. I don't know my slides.
No, they were all quite good. Only in a few places we had that black patch. So when you did not do the slideshow, we saw the whole slide actually.
Okay, ma'am. I will look to
Very,
it.
very much. But
Thank you,
please
ma'am.
be there because there are questions to
I'm
answer.
there. I'm there.
Now we have the next topic on the assessment of the cervix in the second trimester. This will be given by none other than one of ourselves in the peripheral setup, Patnaik. So just imagine being peripheral setup. What he has gained in his expertise in ultrasound, and he is additional director health services of to Government of India, Government of Odisha, senior consultant in obstetrics gynae. He is a laparoscopic surgeon. He was chairman perinatology committee of FOXI. That's why his access to good ultrasound capabilities. Then he is secretary cum treasurer, Association of OBGYN of Odisha, vice president in 2016, and joint organizing secretary cum treasurer in ASCON, Bhubaneswar in 2016, which was a marvelous conference which all of us enjoyed. Then he was joint organizing secretary of the marvelous AICOG, 61st AICOG, which everybody remembers, in 2018. National executive member of IFOM, chapter secretary of IFOM Cuttack chapter, and he's managing director of Abhay Ultrasound. You always see his ultrasound. That's so. In order to master ultrasound, you have to keep at the transducer, at the probe, and go on with it. Now we have Abhay. So all of you should feel encouraged everywhere that one of you has gone to the top and he's now sharing his knowledge with us. Thank you. Please, Abhay.
मैडम नमस्कार सर नमस्कार सर श्रीकांत कोची हाँ नमस्कार सर सर am I audible हाँ सर
Abhay, start sharing your screen.
So, can Sambit share the screen because I have some problem with the internet.
Okay.
There may be caught in the
please
meantime.
Share Abhay sir's screen.
Okay, madam.
मैडम सार फुलपाने बहुत भलो काम करथिन सर मैडम नमस्कार
मते कहया पड़िबनी मु जानि छी अभय किए
नहीं सर ऑडियंस को आपने कौन सर मैडम ऑडियंस पे कौन आपने पे कौन मैडम ऑडियंस पे कौन आपने पे कौन मैडम
Good afternoon all of you. There is a very good concept by Professor Shama madam to start with this training to the specialist of the state, and it is actually a very good concept, and it will definitely help the specialist to learn more, and they will be inspired to do the ultrasound in the hospital, respective hospitals. So I think it is a very good beginning, and it will definitely continue to help the specialists in the state. Thank you, madam, for your initiative, and I also congratulate the Hasmukh sir for continuing and giving advisor to this basic training course, and he was also a mentor in all the ultrasound webinars also. I thank him for helping us to do this webinar for the specialist. With the respect to Professor Ashok Khurana, that he is also mentoring this training program in spite of his busy schedule. I also thank him for inspiring all of us to conduct this training program. So all you know that, next slide. So all you know that is cervical assessment is very important. Next slide, please.
You'll have to go to full screen, Abhay.
Sir, so he has to do, Sambit has to do.
Sambit, full screen.
So there is problem with my video, so I am speaking only. You
I see.
cannot
Okay.
see me because there
Yeah,
is some problem in the internet. So I am doing it from the office.
Oh,
Office.
good.
So,
Yeah.
let us start with the share the screen. So let us start with the cervical assessment, which is very pertinent subject, because we have to predict the preterm labor. Because you have to predict the labor in time so that you can prevent the preterm birth. So that is one thing. We must be astonished to know that India is the highest number of preterm births in the world. So as the statistics given by Dr. Hasmukh Lal, the India, I didn't know also that India is the highest number of preterm births in the world. So this is the time that you should take action. We should know, I should predict the preterm birth and the early stage so that you can prevent the preterm deliveries. So it is important that, so you are not getting the slide, sir. We are not getting the slide.
Okay, Abhay sir, next slide is about learning objective. Are you able to? Why don't you use your mobile and see the slides? Apan pathaychanti jota you have sent it to us.
We are also not able to see it.
Yeah.
So I don't think other people, audience will not be able to see.
Happened, Sambit? Hello? Sambit?
हेलो आज्ञा मैडम नमस्कार मैडम मते टिके होस्ट कर दियंतु
हाँ करुच
आज्ञा मैडम मैडम मो मजे इंटरनेट प्रॉब्लम पे डिस्कनेक्ट है
Yeah.
अरे होस्ट केमती करियो
आज्ञा मैडम साइड रे पार्टिसिपेंट जो लिस्ट आछी सेतरे मो
हाँ,
ना
कली।
मोर रे जाएगी क्लिक करन तो मेक होस्ट कर देले
मोर मेक होस्ट कहीं आसुनी आउथरे जाउची रो
मैडम मो स्क्रीन रे विजिबल होची
हाँ
राइट विजिबल नहीं
मेक होस्ट कहीं देखा जानी
मैडम मोर रे आसीबो
मोर रे तो कली
नहीं
Ask
मैडम
to start.
मैडम पार्टिसिपेंट यस मैडम हे
हाँ। हला
ओके हेला
Now full screen.
फुल
Yes.
स्क्रीन है
और फुल स्क्रीन न हो से तेरे चलो देखा ए कौन पुनी ब्लैक हे गला एटा पुनी कौन ब्लैक है कहीं
Possibly this is due to internet. Actually, internet ର slow speed ପାଇଁ ହଉଥିବ ଏଟା.
स्लाइड
ଏଇଟା
शो
ମ୍ୟାଡାମ
करो
ସେଇଥିପାଇଁ ହଉଥିବ ଇଣ୍ଟରନେଟ ପାଇଁ ହଉଥିବ କାହିଁକିନା ମୋର ସବୁବେଳେ ଜୁମ ରେ କେବେ ବି ଏମିତି ଆସେନି ତ ମୁଁ ଏତେ
आज्ञा मैडम इंटरनेट इशू पे ही होतो बोले इशू
ହଁ କଣ ଗୋଟେ ଇଣ୍ଟରନେଟ ଇସୁ ପାଇଁ ହଉଥିବ କାହିଁକିନା ମୋର କେବେ ବି ଆସେନି ଆଜି ଫାର୍ଷ୍ଟ ଟାଇମ ସବୁ ଲାଗ ଦେଇଥିଲା
ओहो this never happened before also
ଆଜି ତ ମତେ ସେଥିପାଇଁ ମୁଁ କହିଲି ମୋର ତ ସେଟିଂ ଠିକ ଅଛି କାହିଁକି ଲାଗୁଛି
anyway audio is at least there
ଇଣ୍ଟରନେଟ ଯାହା ବି ହଉ
अभय सर तुम स्लाइड तुमको देखा जाऊनी
हाँ खोले मो हेला
start you can share Abhay you want to share
yes
share screen and let's see Sambit stop sharing so that Abhay can share
is it visible
No, you start sharing because Sambit stop sharing. Black shadow ଆସୁଛି ସମସ୍ତେ ଦେଖୁଛନ୍ତି ସେଇଟା. Abhay start sharing.
Yes. You'll start sharing, na?
Yes.
You share.
Okay, just a minute. Is it visible now?
No.
No.
Just a minute.
Please don't leave the meeting. It's a very important topic again.
There is some, I have already loaded the slides. So I'll share just
The
now.
slide
Yes.
minimize it and then share screen.
Yes. Share the screen, no? Share screen.
Yes.
Share screen to TP. First PPT ଟା ଆଣ. Now we can.
ଭାଇ ଆପଣ ଦେଖଉଛି
It should come up that way.
Yeah, it's come.
ଆପଣ ଗୋଟେ ଯାଆନ୍ତୁ ଆଉ
But view
Just come.
normal.
ସବୁ
View
ତ ସେଇଟା
normal.
come.
Let view normal.
Is it visible?
Yes.
Visible,
You have
but
to go to full
the whole.
screen. Up,
Now
perfect.
it's visible.
now visible.
full screen.
Perfect. Yes.
Go ahead.
Now you start.
Then learning objective at the end of this lecture should be able to visualize visualize and measure the cervix in the pregnant patients with vaginal sonography, and identify and manage the pregnant patients with short cervix and manage the patients with threatened preterm labor. So that was the aim of this lecture. This is the aim of the lecture. Then I will tell you so how important it is to see the and measure the cervix, because all you know that the preterm labor is a great issue for the perinatal mortality and morbidity, and you should always prevent the preterm labor because there is a high amount of perinatal deaths due to prematurity, besides the birth asphyxia and septicemia. So therefore it should be predicted early enough to prevent the preterm birth. So correct method of techniques to be used to measure the cervical length, and I will tell you how to take a correct measurement in these lectures. So all you know that this is about the measuring the cervix in the when it is in the abdominal methods. Abdominal ultrasound is not proper to measure the cervical length. Sometimes we see that due to obesity, due to the distance of the probe, due to the fetal organs, fetal parts which obscure in the measurement, and so that it is perfect measurement cannot be done in the abdominal transabdominal ultrasound. Therefore, it is mandatory to have the transvaginal ultrasound to be done for measuring the cervix. So it is usually done in the 16 to 24 weeks scan when we are doing the anomaly scan. But till date we are no protocols to see for the cervical length measurement in all antenatal cases. So therefore we are doing only those cases where the history of previous second trimester spontaneous abortion, or when the patient is having pressure or backache or lower abdominal pain in the early second trimester, we screen them. But it should be a mandatory, in particularly in India, where there is high number of premature delivery. While doing the second trimester anomaly scan, it should always be mandatory to measure the cervix transvaginally to predict the shortness of the cervix. So it should be mandatory. I think Dr. Khurana will agree with me. So in the cervical length, sometimes there may be erroneous in the measurement of the cervical length. So if you have to do correct measurement, you have to see for some of the measurements where, some of the measurements which may mislead you, because there can be the uterine contraction, lower uterine contractions in the which is seen sometimes in lower segment, which will mislead you during the measurement, which gives a larger length the cervix. So you have to be careful while seeing the measurement. It should be done for a long time, for 5-6 minutes. You have to wait and see whether it is actually the such a length of cervix, or there is a lower uterine segment segmental contraction. So that you can see a funneling. You can funneling also can be seen in the also is a predisposing factor for the short preterm labor. Also, it can be measured in the measure which can be measured in the this thing by transvaginally, and perfect measurement can only be done by transvaginal methods and not by the transabdominal method. So a short cervix can only be measured only by because the probe is always nearer, and the strength is also higher, and it gives a proper image when it is close to the cervix. So it gives a better measurement, and so that he can take the action as per the measurement length of the cervix. So sometimes we see if it is a full bladder, so it will also mislead. It will mislead in the transvaginal ultrasound. If the full bladder is there will be stretching of the lower uterine segment, lower uterine segment, as well as the cervical length will be higher, will be greater if we put a you will do on the transvaginal ultrasound also. So you have to keep it empty bladder. So you have to empty the bladder before the doing the transvaginal ultrasound, because in the same patient, if you measure the cervical length so much, but after the evacuates the bladder, you see that cervical length is 14 millimeter. Previously it was measured as 27 millimeter. Or also it may obscure the funneling, because it will pressure over the upper lip of the cervix, which will obscure the funneling. So you may miss the funneling. So if you do the full bladder technique, so therefore it should always be done in the empty bladder. So the different studies have shown that in the cervical length, normal cervical length in the study in the 16 to 36 weeks, in the most of the cases it will be more than 30 mm in the length. So that is the normal. More than 30 mm is the normal cervical length between the 36 weeks of gestation. As you know that it is a dynamic structure, and gradually as the gestation proceeds, and this gradually the length of the cervix decreases until it delivers at the 37 completed weeks. So this is how you should know that the normal cervical length must be more than 3 centimeter and above. So another study also shown that the 13 weeks 23 weeks cervical length in the singleton 2,567 pregnancy cases were taken, and it was seen that when the cervical length is below 15 millimeter, so that is if the cervical length is above 15 millimeter length, there is definitely higher risk. There is definite higher risk of delivering within 7 to 10 days of the pregnancy.
Someone please mute your slide.
So
Someone please
when
mute.
the cervical length at 23rd weeks in a singleton pregnancy, you see that is less than 15 millimeter, there is highest chances of delivering prematurely in that particular case. So this was a study conducted by several authors, by stalwarts. So this is the protocol for cervical assessment by the Fetal Medicine Foundation. That how to do, the patient should be in the gynecological position or the lithotomy position in the empty bladder, and the vaginal probe should be entered and 5 millimeter megahertz in a lubricated disposable clip, and gently place the probe in the anterior vaginal fornix and ensure the sagittal view of the cervix is obtained. So you have to from the introitus while you are pushing in, going in, going in. When you put the probe on the anterior fornix, stop there, slightly withdraw the pressure, so that get a sagittal midline sagittal picture of the cervix at that point of time. But it has to be zoomed, and it's a large image, 75% of the screen to be done. So the zooming is done because of the accurate measurement to be done from the external to internal loss. So identify the internal loss, identify the external loss, identify the cervical canal, identify the endocervical mucosa, which is by side of the cervical canal, it is hypoechoic, you have to see. So identify internal loss, external loss, cervical canal, endocervical mucosa, and also you should be aware of the segmental contraction of the uterus, which may be present, which will interfere with the your measurement, because it will give you a higher measurement. So you should avoid the segment. So you have to wait for 5 minutes. You have to measure for 5 to 6 minutes. So while measuring the cervix, you have to see whether it is there or there is the segmental contraction is there or not. So avoid excessive pressure with the probe, because it may cause inaccurate estimation of the cervical length. So there may be pressure which may stress the cervix, so that you should not give much pressure, because it's soft tissue. So it will be there will be indentation, there will be stretching, there will be length will increase. So therefore you should not just put it over. While measuring also, abdominal circumference might be showing well. When you abdominal probe you put, there will be indentation of the abdominal wall. So therefore you should not put so much of pressure. It should be lightly placed on the anterior fornix. So important thing is that you should see that both the width of both the lips, anterior lip, posterior lip, should be of equal width, and there should be echogenicity should be same in the both anterior lip and the posterior lip, so that we will see that it is a clear picture in the sagittal length. So take time, at least take the 3 measurements and use the shortest. So you have to take 5 to 6 minutes to measure it and take the 3 measurements and take the shortest out of the 3 measurements. That will be the final measurement for you. So coming to this measurement, you see that there is a segmental contraction which you are seeing here. Sometimes you get a report there is a fibroid in the lower segment. Also in the abdominal examination, also you see, you report that fibroid examination, but after the second trimester, third trimester examination, you see that fibroid is gone. But that is not actually the fibroid, which is due to the segmental contraction of lower uterine segment. Sometimes you see. So you have to wait. Same patient, 6.7, then come out to be 3.7 centimeter. Once the contraction is over, so you have to wait and see. So this is the picture of the cervical canal with the cervical mucosa. So it is important to know that the cervical mucosa is your indicator. Indicator will indicate you where you have to see for the internal loss. Because unless you trace the cervical mucosa, you cannot know what is the point, exact point where the internal loss is. So internal loss is the end point of the cervical mucosa. So that is the clue to measure the internal loss. So you should always measure. Don't measure from the internal external loss to the inner port of the anterior lip, posterior lip. So you have to see the cervical mucosa at the end point of the cervical mucosa. That is the internal loss, and you have to measure from the external loss to the internal loss at that point. So that is the trick of measurement of the internal loss. So sometimes you see that this is the pictorial representation that you may see, but actually the internal loss is here. But we are seeing that the lower uterine segment, there is contractions, and therefore you have to wait for 5 minutes, and once it subsides, then you can take the measurement. But you have to trace out the cervical mucosa, which is hypoechoic space surrounding the internal cervical canal. So when at the end point of the this is called the internal loss. So you have to measure accordingly. So important thing is sometimes you see that there is a false, if you are not properly doing a proper technique, so you may see that there is a funneling. So the patient rushed at night for emergency circulage, and when she was admitted, and when in the morning upon admission it was taken that the same patient having no funneling. So technique is most important, and patient should be in the empty bladder and should be in the quiescent state, so that you can have a better measurement. You will have a so that you can predict, because otherwise it will give you a false impression of the funneling, or false impression of higher length of cervix. So you have to, technique should be proper. So coming to the cervical length measurement in funneling, sometimes you see there is funneling which occurs in the prior to the shortening of the cervix. Sometimes you see prior to the different types of funneling can be seen in the internal os. So which should not be included in the measurement of the cervical length measurement. So length A and length B, you see that the length A is the funnel length, and the particular functional length of the cervix is from the apex of the funnel to the external os. So that is actual cervical length, or the short cervical length, which is to be measured. This is not that you should measure from this point, or you should always measure from the apex of the funnel to the external os. That is actual length of the length of the cervix in this case. So types of funneling, that is pictorial methods. This can be T type is normal, and Y type is the initial funneling. What V type, you see that the funneling is increasing, and U type is the usually seen that the highest part of the highest point of the funnel. High funneling with the short cervix. So this is how the pictorial representation of the different types of funneling, which is sometimes seen prior to this the cervical length shortening, and also accompanied with the cervical length shortening. And this can be of the different grades, which was produced and pictorial by Phillips Genti, great sonologist. And this is how we see in the ultrasound picture. So this is the T type, which is normal length cervix, or Y type, there is mild funneling, there is a moderate funneling, or severe type funneling. What we see during the examination or the examination. So it is seen that you have to see this, and the measurement should always be from the apex of the funnel to the external os, apex to the funnel to the external os, and this is from the apex to the external os, and apex to the external os. So it is seen when there is funneling, only funneling has very little significant, and the funneling with shortening of the cervix is more significant. And you see that if the short cervix is there, so you have to measure with C for the funneling. Is funneling associated short cervix, then it's more supposed to deliver prematurely. So another thing is the cervix is short, you should do soft, and you should avoid pressure over it, and you should see that both the leaves are equal width and equal echogenicity in both the leaves, so that if you give pressure, there will be indentation of cervix, there will be stretching and lengthening. So you don't have to give pressure. So you have to just put it on the anterfornix. So while putting in, what I was telling, exert some pressure to identify the cervix from the introitus to you are going in, and you see that the cervix is seen at the sagittal plane, and just release the pressure, and you see that the complete picture in the plane sagittal plane. So this is how you measure. So is the external os to internal os, we are measuring the cervical length. So also you can measure by putting a linear line along the cervical canal, or if it is cervix is too curved, you can put the two straight lines and adding on the curvature, two straight line adding and making the measurement of the cervix. But mostly it is important to know that most of the short cervix are straight, and when it is curved and long, it is no needed to be measured, because it is always a large normal cervix. So normal length of cervix, we have got many significant to know that it should be more than 3 centimeters always. So while a method, this is the method how we are measuring from a straight line from the external os to the internal os. That is the ideal method of measurement while doing the measuring the short cervix. So another study which showed that the cervical length and obstetric history predict spontaneous preterm birth development and validation of model to provide individual risk assessment. So it was a study by the Nicolaides et al. And they have seen that screening by a combination of obstetric history and cervical length provides a higher detection rate than either method alone. So when we are doing, because sometimes we see that she has have 2-3 spontaneous abortions, in those cases you take the history and do, if you detect at the 16 to 24 week scan, if you see that cervical length is reduced, and it will guide you, give a more confirmatory method, and so that we can detect and preventive methods to be done to prevent the preterm labor. So also it was seen that by asymptomatic sonographic short cervix in the mid trimester treated with the in 775 women, significant reduction risk of preterm birth up to 33 week gestation by giving vaginal progesterone up to 33 weeks. So it was a study which shows that the vaginal progesterone can be given, or now we are giving the oral progesterone, which can be given to prevent the preterm delivery if you start it early at the before the early part, so that you can prevent the preterm delivery. Another study also showed that delivery in 216 women between 24 to 36 weeks with painful contraction, it was seen that when the length of the cervix is less than 15 millimeter, and there is highest chance of delivery within 7 days. So it was study when there is a painful uterine contraction in 24 to 36 weeks, and cervical measurement was done. It was seen that length when it is less than 15 millimeter, so is the highest chance to delivery within 7 days. So within 7 days next week. So randomized control trial also been seen with the control and cutoff on delivery with less than 34 weeks in the control group as well as in the cervical length group. It was seen that detection rate of higher in cervical length group, and unnecessary control group, there are unnecessary steroid in the control group, and tocolysis was unnecessarily used in the control group, whereas the cervical sort of length group, we have seen that it is a prediction is much more, and delivery could be prevented up to 34, less than 34 weeks. So that was the study conducted. So all other studies also been detected by positive fibronectin, no fetal breathing or short ultrasound cervix. Also the fibronectin what you are previously being using, the fetal fibronectin, the fetal fibronectin also can detect the condition of the preterm labor who will go to preterm labor. All you know that the fetal fibronectin, the vaginal swab is collected from the vaginal posterior vaginal swab, and it is transmitted through the media, and it is tested, and if it is more than 50 nanogram per ml, it is see then it is positive, and it is positive only there is chance of detecting the preterm labor, which is also a very definitive method. So we see that but these methods of testing of fetal fibronectin are not available everywhere. So it is better to go for the cervical length assessment, because we don't have this facility with us. We are not able to do fetal fibronectin at present with us, though it is very simple method, but it can predict equally effective as per the cervical length measurement. So cervical length also is quite effective as well as the so this is how you do the threatened preterm labor. The patients are coming, they're measuring the cervical length. If it is more than 15 to 30 millimeter, with the fibronectin negative, there is low risk. If the length is more than 30 millimeter, that always a low risk. If 15 to 30 millimeter with fibronectin negative, low risk. If fibronectin positive, then it is high risk. If less than 50 millimeter, then it is high risk. So it is also seen that if you can also see that the only labor when you see that cervical length measurement, if it is less than 15 millimeter is high risk and more than 30 millimeter is low risk. So this can be very simpler procedure that can be done. So this is how you have to meticulously to be done, and it should be perfectly measurement is important and to predict the preterm labor so that you can take the preventive methods to prevent the preterm birth. So this is the key points. The transvaginal approach should be used in preference to the transabdominal approach when examining the cervix with ultrasound. But sometimes we may not be able to do in the transvaginal approach when there is bleeding, where there is leaking. In those cases, transperineal, but I have never tried transperineal. Very difficult to assess the anatomical structures which coming transperineal. But Professor Khurana, Husnukulal, other seniors, they may be doing. But in those cases, we usually prefer to go again transvaginal. Also, you can do a digital examination. Also, sometimes in the leaking, previously what we didn't have anything while doing PG, we didn't have ultrasound with us. We are only doing digital examination or Hager's dilator prior to pregnancy, 8 weeks Hager's is passing or catheter is passing, then we are diagnosing. But now in the era of ultrasound, you should always approach with the ultrasound to measure the cervical length, whether she is either screening in the 14 to 24 weeks or 16 to 24 weeks scan, and or you have to have the patient with a bleeding or a patient with having pain or with the pressure or backache in the early part of the pregnancy. You have to approach through the transvaginal ultrasound cervical length measurement. The correct technique should always be used, and the care should be taken not to overestimate the cervical length, because if you will overestimate, she may deliver, so there will be fallacy in your measurement. So excessive pressure, the probe should be avoided and measuring the cervical length. So coming to this is the last slide, and thank you that I have given some of the knowledge and experience what I have achieved during my career course through the ultrasound.
Please show your last slide. Show your last slide, please.
Next.
Previous one.
Yeah. So this is the key messages that it should be always a transvaginal approach, and the correct technique should be always be used, and care should be taken not to overestimate the cervical length. Excessive pressure with the probe should be avoided to measure the cervical. Most important thing I have to say that it should be a mandatory in 16 to 24 weeks in the anomaly scan, because before that there is isthmus of the cervix which is not developed into lower uterine segment. So if you do less than 16 weeks measurement, there will be a fallacious measurement. There will be a false high length will come. So therefore, we are not doing before 16 weeks cervical length measurement. But when we are getting this less cervical length or the short cervical length at the 11-14 week scan, then it is very, very important. It should always be important to be given that it is always to be treated immediately, or circulates to be given immediately, because you are getting at the early part of the pregnancy, you are getting a short cervix. But ideal to have 16 to 24 weeks scan to detect the short cervix. That screening is usually the universal screening should be done. Thank you, madam.
Abhay sir, can you tell about that app Quip? Please tell about Quip. There is an app available. Shyama madam knows it. Yeah.
Yes,
Hello.
you can speak about it. What about Hasmukh sir? You can highlight on that app.
Okay, Quip is an app you can download from your Google Play or from your Apple device. It is developed by the King's Hospital, and you have to simply fill in what is the cervical length and whether the woman's age and what did she ever have a preterm birth before, and if you fill in all those columns, and there is you can do it with fibronectin or without fibronectin. If you don't have a facility for fibronectin, there is no problem. You just fill in the rest of the thing like CL, the cervical length, and it gives you a risk factor. Very easy. So
Okay, thank you,
try
sir.
it. I think I have also put it in the chat box, the same thing.
Yes, now, thank you very much, Abhay sir, for a wonderful presentation and clarifying so many aspects on cervical imaging in second trimester to prevent preterm labor. I think all our specialists will now, hopefully, we can start straight away in preventing preterm labor, download that app, even though we know fibronectin is not available even at SCB, and it is pretty expensive also. They, I think once or twice, one postgraduate had done a thesis and it was done in the biochemistry department, but it's not available for all. And so questions are invited now. And until you are ready with your questions, I would ask Professor Khurana to give his post presentation inputs. Before that, hello? Hello, Professor Khurana, is he there?
Yes, I'm right here. Yes.
So stop sharing your screen, Abhay.
Yes, yes, madam.
Thank you very much. So you and Josna, please be there.
Yes,
Anybody can put any questions in the chat box also. I think some of them are there already.
Yes.
There was, yeah. Professor Khurana, please speak, and then I think I will tell about the question. Yeah, one is for Abhay Patnaik.
After post poll.
After, yeah.
After post poll, you will discuss questions.
We need Ashok Khurana sir's comment.
Yes. So we have had the privilege
We
of
start the post poll in the meantime also.
I think
Hello?
let us listen to Khurana sir first.
Okay.
Thank you very much. It's been yet another very fruitful afternoon, and we are only 2/3 of the way through. What I really like is the open-ended program we have here, and we've discussed several very important points today, but really looking at the fact that preterm delivery is such a killer in every part of the world, and as we already know, it is India is the world's capital for preterm delivery. We don't have as many iatrogenic preterm deliveries as we have spontaneous preterm delivery. That to be able to screen for this at the right time seems to be wonderful. And the data, as you have heard already, is very clear and straightforward that it is the best way to go about in terms of singleton pregnancies. Also, the fact that doing nothing for your findings is no longer an alternative. And it is not just a question of a surveillance of that mother, but actually active treatment to prevent the preterm delivery. We've also
Ashok sir, you are, please unmute yourself. Ashok sir, please unmute.
Are you hearing me now? I'm getting automatically unmuted. Yes. So I was mentioning that, yes, for singleton pregnancies, we know that we should treat. And we've been able to categorize our patients into those with a previous history, those with a possible cervical incompetence, and those where we truly look for the preterm delivery. We know that fibronectin is scantily available. Also, the newer data from fibronectin seem to indicate that a well-done transvaginal scan is really a fairly good method of stratifying patients to get equally good results. When ultrasound is not available, of course, then a clinical evaluation of fibronectin have a lot of value. What I would like to highlight is something very simple, that at the time of your anomaly scan, which now, we have shifted, instead of 18 weeks, we have shifted to the 22-week window, we do an excellent transvaginal evaluation. We've also learned that transabdominal evaluation is not as good, that it should always be transvaginal. It has to be done with exactly the wonderful technique that you have been shown. And when you get that, then you stratify your patients right away and you realize which ones are the ones that are going to need a surveillance and which ones are the ones that need to be put in straight away onto progesterone. And it works. It truly works because we're able to prevent preterm delivery in 50% of those patients. And out of the remaining 50%, we're able to postpone the delivery by a reasonable number of weeks. The third thing we're able to do is it gives us enough time to know that, yes, do I have time for steroids, etc., etc. The question of assessing a transvaginal evaluation at the 12-week window is really for the patients with the previous history of a pregnancy loss, because in those you want to know whether a cerclage is required or not. So those we assess at the time of their 12-week scan, and then you assess every 2 weeks after that to make sure whether they need a cerclage. And of course, the patient now has an alternative of progesterone. Progesterone has also come a long way, and we have learned during these talks that yes, the question is which progesterone should we use, and we will discuss that in the question and answer session. The other equally important thing that we have learned is that you can predict preeclampsia beautifully at the time of the 12-week window. We've also learned that it's a great time to actually look for fetal anatomy using color, and that it is safe. And it's a question of getting more and more used to it. When we encounter these things for the first time, one develops a sort of mental block. I can't do it. It is not possible. I have too many patients. If I devote this much time to this many patients, then what will happen to the rest of my patients? What will happen to my surgical work? What will happen to my long list of patients who have come in for the regular antenatal clinic? What is going to happen to my antenatal clinic in terms of my high-risk pregnancy clinic? These things happen all over the world. The more we do this, the more you can do in the same time period because you acquire that skill and it doesn't take you that long. Therefore, I suggest that we start doing this without the mental block. If we keep our mind open, we will always succeed in actually being able to get these answers correctly much faster. And then you don't have to worry that, oh, is this short, is this not? You practice this in your mind, and within a minute, all it takes is empty the bladder and the patient comes back. Actually, what I often do is we have 2 beds in the same examining room. So you put a screen between them and you take the transducer around and you're able to turn the screen around and you can do it. So you don't actually lose time in patient going and coming back. So you have to develop these methods given our limitations, given our patient pressure, because that is our primary purpose in life. Every mother is precious and every fetus is precious. And we are screening not for simple things, just Down syndrome. Down syndrome is 1 in 800 to 1 in 1,000 pregnancies. Preeclampsia in certain districts of interior Odisha, as I used to call it in my time when I was growing up, is as high as 33% of that population, because that population has an ethnic risk. So we owe it to our patients to screen for preeclampsia. And even if the biochemistry is not available for whatever reason, just this one single reading of the uterine artery Doppler will justify, because this patient may or may not come back to you, it will justify her using low-dose aspirin in that particular pregnancy. It's exactly the same thing with preterm delivery. We save so much in terms of nursery care of the premature and the low birth weight newborn that it is something that you and me must use, and the liberal use of progesterone. So I'm really looking forward to each one of you realizing that the only way to clear your mental block is to start doing it. There is no shortcut to learning these, but the learning curve is what we call very steep. You do your 10 cases, you take time. You do your 20 cases, you take no extra time. You do your 100 cases, you wonder, why did I ever think about it in such an alien way? It becomes part of your routine examination. So please do start doing it. And the apps really help you to make calculations. So download that Quip app as soon as you can and get going.
Professor Khurana, I have a question here.
Yes.
Supposing the pulsatility index for that gestational age is not as high for predicting preeclampsia, if Gestosis scoring is used, and you have 3 scores, at least the score is high.
Yes.
Can we give low dose aspirin?
Yes.
Even if
You
the
see,
pulsatile index is not high?
True.
Will it be,
You can actually use.
supposing an elderly primate, she has
You
hypertension,
see, she has a
pre-existing.
mother who has been hypertensive,
Yes,
and
yes.
her blood pressure readings are 128/84, for instance. We do on exactly the same app, you can do it without the biochemistry and without the uterine artery. And you have either the gestosis score or you have the points allotted. We have an ACOG formula, and we also have an RCOG formula. We also have one from Canada, one from Australia. For each one of these, even depending on ethnicity, you can start low dose aspirin. The only thing is that when you do the uterine arteries, it's a very good idea to do this. Even
Yes, it's
the
much more specific.
uterine artery, if it's not in the absolutely abnormal range, but we combine it with the others, you will find that the patient will come to high risk. Unfortunately, the gestosis score represents a compromise of modern technology. What we need to do is to realize that the use of ultrasound is truly inexpensive compared to the long-term expense of looking after the hypertensive mother and the small 4 days baby. So therefore, it is something worth investing in. So if we start with a compromise such as the gestosis scoring, we will never move on. Our degree of identification in the validation study of the gestosis score was fairly decent, about 60%. However, my basic experience with the gestosis score in Gurgaon, where we did not add the uterine artery, what we call the real world study, is that we are identifying only 40% with the gestosis score. And if you use similar criteria from the ACOG guidelines, they are able to identify only about 29%. Now, that is not good enough for a screening program. A screening program must identify 65% of the patients at risk. Gestosis does not do that. It is the ultimate compromise, and I don't think our women deserve such a compromised approach. When you're desperate and you have nothing else, I'd rather just use my clinical sense because I have that clinical sense. I don't need a gestosis score. The gestosis score is a false reassurance for me to say that I am justified in using a drug like low-dose aspirin. But let me look at what I used to do and the outcomes and what is being done by the gestosis score and the outcomes. It has not changed anything in terms of its application. So if my validation study has shown that I was having 72% of preterm deliveries previously at 32 weeks, and after using the gestosis score, I am still having to do the same number, it has not served my purpose. It has only told my patient that, look, don't deliver at home, but nothing beyond that. I have not been able to postpone my prematurity, and therefore it doesn't work. I have to catch
There's another
that
question.
group. Yes.
Yeah. There's another question. Should we give aspirin to all?
The problem with giving aspirin to every single patient is that we have to compare the risks with the advantages. If the patient gets preeclampsia and she has a small 4 days baby, we will lose a small number of people who will have the complications of aspirin. Exsanguinating hemorrhage by an upper GI bleed and intradural and intracranial bleeding occurs in about 1 out of every 600 patients who is on low-dose aspirin. And that is not a small number. So therefore, we are not justified in using low-dose aspirin for everyone. So this is something that we must be very careful about.
Any more questions on the chat box?
There was one question as to the what type of progesterone to use and the doses actually.
Yes,
I
yes,
think
yes.
someone had asked about doses. Yeah, loading dose.
No, dydrogesterone should doses of dydrogesterone in second trimester.
Yeah.
Dose of aspirin, somebody has asked Chinmaya Panda. It has been repeatedly told by Professor Khurana before this, and today also by Josna Madam has said that it should be 150 milligram. 75 will not do. I think Professor Khurana, am I right?
Yes,
Yeah.
you see, we have what we call aspirin resistance. 1/3 of the patients will be resistant to using low dose aspirin of the 75 to 80 milligram variety. In fact, all this information came out as far back as the late 80s. It was part of a Canadian study. It was part of the study for coronary artery disease. And we did realize that 1/3 of patients are resistant to low dose aspirin when we take it at 75 milligrams. And it was only that commercially it used to come as 75 milligrams because permission for that had already been given by the Food and Drug Administration of the United States. Unfortunately, that is stuck in our head. But we cannot afford aspirin resistance because 33% of patients will be resistant to low dose aspirin. And out of the pregnant patients with a high risk, 55% will be resistant to 75 milligrams of aspirin. So we have statistical evidence to tell me that I must use at least 70, I must use at least 150 because that is correct. 2.4 mg per kg is the dose that we like to use for non-resistant. So if you have a tiny patient, that might be different, but always calculate it on the basis of body weight in case you're thinking of giving her less, 2.4 mg per kg. And always give it at night for 2 reasons. A, because the maximum dose, the blood level will then be at the time between 4 a.m. and 6 a.m. when the coagulability of the blood is the highest. And therefore we give it at night. The second thing is you give it after dinner, then the degree of gastric symptoms and reflux will be the least. And therefore it's a good idea to give this at night. And our biggest problem has been the patients and the compliance. Compliance is something we must ensure. So the whole family should be told that, look, this is a magic pill. It's inexpensive, but it's a magic pill. And please make sure that someone puts it into her mouth every night and she takes a few sips of water and she has it. Because the only reason we fail to prevent preeclampsia when we are giving aspirin is because there is poor compliance.
Effect of aspirin on preventing low birth weight and preterm labor. Somebody has asked, I think.
Yes. So we know that the second, we've heard already today that the second phase of proliferation of the trophoblast into the endothelium, into the spiral arteries actually takes place after 16 weeks and stops at 24 weeks. Therefore, for preventing preeclampsia, we don't do too much of a good job if we start aspirin after 16 weeks. On the other hand, for reducing growth restriction, for reducing the severity of preeclampsia, and to a certain extent, for preventing preterm delivery and generally improving the outcomes of pregnancy, you can actually start low-dose aspirin later in pregnancy, but there's only a modest increase. Only 10% of things will be prevented. But for that patient who benefits from that 10% benefit, it's a drug that is worth it. And therefore, when you have a clinical situation, a patient, for instance, who has had a lupus, who already has an antiphospholipid antibody syndrome, who has low-dose aspirin, who has a history of some other disease, it is worth starting the aspirin at any time of the pregnancy to improve the outcome, but not for the prevention of preeclampsia. We must separate the data very clearly on both these points.
Along with the aspirin, should high dose calcium and antioxidants be given because our women are poorly nourished, and
Yes.
high dose calcium also has a role for preventing platelet aggregation. So what do you recommend? So
we know that in calcium deficient patients, they will have a risk of preeclampsia, and therefore for all our patients who have a deficiency of calcium, they should be given calcium. Luckily for us, we anyway started at the right time. Our second group is what kind of supplementation should we give for the patients who are poorly nourished? The first thing is regular meals. The second thing is the composition of the meals. Antioxidants, unfortunately, add up to too much. And we really have to be careful on not prescribing medication when nutrition would be far better. Of course, in the patients who get a supply of antioxidants from the hospital, that would be all right, but we have to save money somewhere. And therefore, the important thing is to realize that natural nutrition is the best answer. The next is the question of of arginine, for instance, which has been used to improve pregnancy outcomes, and some of the omega-3, etc., the fact remains that the improvement in outcomes is not statistically significant. So really, we get stuck with a very simple, straightforward point. The answer lies in low-dose aspirin and surveillance.
Two more questions. One is dexamethasone or betamethasone, which is better, and when to stop aspirin?
So aspirin is carried on until 36 weeks unless there's an indication for delivery. That's a very straightforward point. The next question is a clinical question, and sometimes I feel very naughty about answering this. Well, unfortunately, the betamethasone compound that we get in India commercially available is not the same as is used in the West. Therefore, technically speaking, it would not be correct until we get that. And currently there is no manufacturer, and the one that we use, which is the betnesol, is not really the one that has been studied. For that situation, therefore, dexamethasone is superior and should be used. It's a little more cumbersome to give, and it's 4 shots instead of 2 shots, etc. But the fact remains that if we look at the pharmacological market today, dexamethasone is certainly superior.
Thank you very much, sir. I have a personal question.
Yes.
To let Josna madam, are you there?
Yes,
Hello?
yes, she's here.
Supposing you get a waveform which is mixed, and can you use instead of and have a short of time, can you use manual tracing for finding
Yes.
out?
Madam, always it is manual tracing. If you feel you can do it, because computer doesn't know what is there. You just switch on the button, whatever is there, it is taking. But our mind is definitely more sharper than computer. So when you see the waveform is bizarre, and when you put auto option, it is taking here and there, either and there, you can jolly well take the option of manual tracing and trace it and give the report.
Thank you. Any more
I would agree
questions?
completely. There is one very important question that has come up in the box, and it's about if we are just stuck with doing a transabdominal scan, what precautions should we take in cervical assessment? We have very clear evidence that a digital examination by an experienced person is superior to a transabdominal scan. Also, what we need to measure, as you've heard in the presentation, is the endocervix. And the endocervix in the vast majority of patients cannot be assessed by a transabdominal scan. Therefore, if we have to assess the endocervix, we will assess it transvaginally. And if I don't have that possibility, then I absolutely must depend totally on my digital examination clinically.
Very much. I think the post-poll questions have been launched.
Yes.
Please, those who are there, please attempt it to give our presenters the feeling that they have done justice.
Madam, can I see the polling? What is there? Where I can see?
After the post-poll,
Achha.
then the questions will be discussed individually by Dr. Hasmukh, and then we'll see how much improvement was there. So now let's go on discussing. If Dr. Hasmukh, would you like to say something about that app, or anybody else wants to ask any more questions? Professor Khurana is there.
I have already told about the app, which is Quip. It is developed by King's Hospital and various other associates. And yeah, it is available on Google Play. You can download it. It is free of cost. And also people using Apple phone can also from Apple store. And it is a very simple app which replies. We have to just fill in some columns there. I think Shama madam, I sent you and Abhay sir both the app. I had sent you somewhere. It is there.
Please attempt the post-poll questions, everybody.
Madam, actually,
sorry
Honest
madam
request.
to disturb madam interruption पे sorry post poll तक के end कर दो जल्दी तो टिके please request समझते को don't
Don't end poll,
press the
please.
end poll button.
Don't press the end poll, please.
Yeah, it will disappear.
Again, you have to give.
Again, you have to do it.
Madam, just one thing I want to say. After the post poll is over, I will share all my slides in the WhatsApp group. Which is, can I share this?
Yes, in the WhatsApp group you share.
I will share the clear slides which I originally made so that everybody will look into it, because I'm sorry for the some internet issue. It was not visible for all. So if you permit, I will share it on WhatsApp.
No question. We're all learning.
Okay.
Post poll questions, please.
And the most important is don't
Sure, all
care
the
to
questions were
handle-
very nicely clarified by the two speakers. So I think there'll be a
It
good.
should be a full bladder should be avoided fasting. So that is 100% now we are seeing post
Wait,
poll.
Abhay, don't give the answers. Let them answer and then we will discuss.
where you are able to see the poll. I am not able to see the poll.
100% have answered correctly.
Madam, where is the poll where I can see?
Madam, if you are logged in from the laptop or desktop, there is a
Yes.
panel in the lower part of the screen.
More.
Pool.
Again, madam, more as well.
Acha, poll.
Share screen
Yes,
pakne
it is a poll. Okay.
Yeah,
Okay,
yeah.
poll.
ठीक,
You
ठीक.
click on the
Madam,
poll.
it is
you
click
see-
करिए, but kindly end
हाँ,
poll.
ମୁଁ କରିବିନି.
Okay,
ଜାଣିଛି.
okay, madam.
ଯିଏ ଭୁଲ କରୁଛି ମାନେ ସେ ପ୍ରି ପୋଲ ବେଳେ ନଥିଲା ଏ
ନାଇଁ
question-
actually ହଁ ନାଇଁ people ବେଳେ ନଥିଲା ନାଇଁ actually ଏଇଟା ନାଇଁ ଠିକ ତ କୁହନ୍ତୁ ମ୍ୟାଡାମ.
It's a nice game. Interesting. So please answer all the questions now. Doesn't matter regarding mistakes. If there are mistakes, means the speakers will be. We are testing the speakers, not you. So go ahead. Don't click on that end poll.
Don't afraid of handling the machine like your video game or whatever you are playing. You don't do anything. Anything you do, again it will be revert back. I think the next talk is Dr. Ajit, no?
Yes. After
Sir,
that, we'll see.
Doppler basics is already completed. They have completed.
Yeah,
Doppler
Doppler
basics
is
is
finished.
done by practice.
Doppler is finished.
Asmuklal sir, you can make the all speakers slide in one folder, and you should keep it for the anywhere it may be needed, it may be required.
Yes, madam, we are preparing a folder at the Regional Research Center of UNICEF, Excellent Medical College, Koraput, and we'll share, we are putting all these recordings and PPTs in that folder, and we'll share the link with all the participants.
That is better, so that they can go repeatedly, read repeatedly, and so that any mistakes and everything that could be clarified. And is my personal request, anywhere you find any problem in detecting, you can call me. If at all I am not able to pick up your phone call during scanning, I will definitely give answers to your questions in the WhatsApp if you feel like giving me. Any doubt, anything in first trimester? Because as a protocol, one should be very thorough in second trimester prior to the first trimester screening. One should be very thorough in second trimester prior to the first trimester screening. But the protocol goes first trimester, then second trimester, then third trimester. Otherwise, you should be very thorough in second trimester screening first.
Do even Doppler have to change anything required to change the setting, or it is preset already?
You ask your people when the application engineer comes, you ask to make a Doppler setting, ask your patient to lie down and ask there to set. Suppose you are putting in the umbilical artery, you ask that to preset it as the PRF and everything in a preset, so that you need not have to repeatedly change. But usually for Doppler, you have to manipulate your machine. Very often it is required. Only 4 buttons: PRF, color, and sample get, and the pulse wave, but the all and baseline. 5 button only. You just play with this. What happened? Suppose it will be more get. You see what mistakes we are doing and what is the waveform. Again, you put your PRF high and see what is there. What are you, just in a normal scanning procedure, you just put your pulse wave Doppler, color Doppler first, and go on switch button, change the bottom of PRF, increase and decrease, increase and decrease. You personally know where is the difference. What you by doing what you can get a better image. It will take only 7 days. Only 7 days.
Okay.
But you should understand the Doppler first. Then only you can do that. You understand what you are doing. I am decreasing the PRF means I am allowing all the low velocity flow to come. All the low velocity flows are venous flows. If I am looking for the uterine artery, it is a high velocity of flow. If I put my PRF low, it will not detect the high velocity flow. So I have to put my PRF high, where I can detect only arterial waveform. I cannot detect the waveform of the doctor's venous then. So you should know what you are doing. And if you put your sample get quite wide apart, it will pick up everything, the adjacent vessel as well as the main vessel. So you should put the sample get exactly where to put and how much. Suppose you are putting 2 mm in uterine artery, it is okay. If you put 2 mm in doctor's venous, it will take the hepatic vein, doctor's venous, IVC, everything. So you will get a bizarre pattern of waveform.
Localizing uterine artery.
The post poll, hurry up with the post poll. We'll go to the discussion of the questions. 60 out of 80.
Have they answered which of the following should be avoided while assessing the cervix with vaginal sonography in pregnancy?
Sambit, shall we end the post poll?
Madam, आपण जर कहे तो मैं end कर दूँगी, or else, madam, few participants are still attempting.
60
I don't see any attempts made. Have they attempted?
So anyway, we'll start discussing and Sambit will give us the difference. End the poll. End the poll. End the poll. Professor Dr. Hasmukh Lal, please start discussing the details.
So now let me share. Means in this 90% have responded to full urinary bladder, and that is the correct answer, because we already saw that when the bladder is full, it will elongate the cervix and there will be false measurement. So the answer that A is the right answer.
Those who have answered empty, they have misunderstood the question. Which of the following should be avoided? That means you should not avoid empty urinary bladder, rather full urinary. So difference in the pre and post difference is something.
मैडम प्री पोल क्वेश्चन रे एई क्वेश्चन टर राइट रेस्पॉन्स 71% पार्टिसिपेंट माने देइतले करेक्ट रेस्पॉन्स एबे 90%.
Jump of 20%.
आगे मैडम.
Next. Next
So,
question.
next question, protocol for cervical assessments are single choice. Single choice is, how it is single choice? Why, I think it is not a single choice, because vaginal probe 5 megahertz is the correct answer. Then gently place the probe in the anterior vaginal.
Yeah, all of the above is there.
All of the above is the right answer.
Yeah.
So no, but here it is written single choice, in the just below. So there is no single choice. They can make any, okay. All of the above is the right
All
answer.
of the above is single choice.
Yeah, right, 98%.
Pre and post difference?
Pre and post, madam, pre and post comparison is 97% to 98%. There is no much difference between the pre
It
and
is a
post.
very easy question.
Yes,
Yeah.
madam.
And
Next, third.
segmental contraction of the lower uterus. Again, C is the right answer, because it may lead to underestimation of cervical, may lead to overestimation of cervical length. C is the right
Pre and
answer.
And
Pre
madam,
and
pre
post
and
difference?
post orientation questionnaire response is from 26% to 75%. madam.
This is a good jump.
Yeah.
Uh,
And
Next.
number 4. Number 4. I think where is this questions have been.
Sir, the number 4 question is the wave pattern in ductus venosus.
Yeah, but I think you have mixed it of Dr.
Yes.
Josna slide and
Yes, sir.
ठीक है sir.
नहीं से तीनटा देथिला ऑप्शन मु नॉन ऑफ द अबव गुटे ऐड कर दी
no.
कना
The
चारटा
way-
नहीं मैडम एक्चुअली मो
wave pattern in-
क्वेश्चन गुडा को हमें तेरे पोल क्वेश्चन देइतलु तो जंबल्ड करके देइतलु
No problem. No problem. The wave pattern in ductus venosus is triphasic. Already we saw a slide where there was on S wave, there was one D wave, and there was one A wave. So it is a 3 phases. The S is systolic. See, ductus venosus reflects the pressure and the volume changes in the right atrium. This is we have to understand that pressure and volume both affect the ductus venosus. And I think let me also answer one question. This it was asked in the chat box, how to identify ductus. The easiest way is you just first find out the umbilical vein. In whichever, in first trimester, we always take in a mid sagittal section, and always just follow the umbilical vein, and suddenly you will find that it narrows down. And that narrowing part, we will see aliasing. And that is the easiest way. Follow the umbilical vein. Even in the axial section, the what we call is axial section of the abdomen. There also we try to follow the umbilical vein and straight. There suddenly umbilical vein, it curves towards the right side. So we don't go to the portal vein. Umbilical vein, we go simply straight away, and again we will find the aliasing. That is the point to pick up in second trimester. So
simulators they also have Doppler studies.
So the question.
Yes, sir. Question is triphasic is fine. Just I want to add one thing. Why there is change of wave changes in the venous Doppler in relation to the heart, because venous vein have no valves. So artery has valves. So venous findings is no veins are no valves. So any pressure change can be depicted easier than the artery. That is one point. That's you should know.
Yeah.
Okay.
So, Samrit, what is the difference? Pre and post?
Pre and post orientation difference is from 41% to 84%.
Very
This is
good.
also a good jump. So, Josna madam has rightly explained why it should be triphasic. Next question, Hasmukh sir.
Reverse ductus venosus in first trimester could be a finding in the ductus venosus can be abnormal. I mean, in all of the above is the right answer. The 75% of the people have given the right answer.
So, pre and post.
So the difference, pre and post difference is from 56% to 75%.
Anyway, there's a good improvement. 20% improvement. Next.
Next question is for pregnancy induced hypertension screening, PIS screening in first trimester. What measurement is required? The mean uterine artery. We measure on the both sides. Why we measure on the both side? Because if the side which has a placenta will show a low resistance and the other side will show a high resistance. Therefore, we measure both the uterine artery and take the mean of the two. Yeah, that is the right answer.
And so the difference.
D is the right answer.
Pre and post pole difference?
From 62% to 80%.
Good, very good.
Good.
So the mean difference between the cervical length measured with an empty bladder and the full bladder is, it is 4 mm is the right answer.
4 mm is the right answer.
4 mm is the right answer. And 10%, I think there we have.
No, actually,
I have told during discussion, but they could not get it, perhaps.
All the slides were not visible.
It was not reflected in the slide.
Madam, even in pre-poll questionnaire, also the response was only 8% have responded correctly to this question.
So 8 to 10 difference. Anyway, actually, I hope those who are still there, the 4 mm is the right answer. Actually, the PowerPoint did not show that 4 mm. That's why they have missed it. You have said, but if it was displayed in the PowerPoint also, that 4 mm difference, because that slide showed 27 on one side.
We gave an indirect hint that full bladder will give the longest, almost the very big error. So I think 4 mm they should have guessed, but anyhow we give them full marks, no problem. If it was not discussed. Okay. So what is the normal cervical length at 18 to 23 weeks of gestation? And I think most of the people have attempted it right. The right answer is more than 2.5, between more than 2.5 to 3 centimeter. That is the right answer. So 93%.
Pre-poll jump?
Pre-poll, madam, jump from 86% to post-poll 93%.
Good. Yeah.
Sir, it is 3.5 or 3.
They know that it's 3 centimeters.
Sir, Abhay sir, my question is whether it is 2.5 to 3.5 or 3. 3 is mentioned somewhere.
3.
No, it should be.
This one slide shows 2.5 to 3.
It is above 2.5 because 2.5 is the cutoff shorter length, so above 2.5.
Okay. Now this is my personal question. 2.5 to 3.5 I was thinking, but if it is mentioned,
has been taken in a large population, it is there between 2.5.
No, it can be more than 3.5.
They have long cervix.
It can be more than 3.5 also.
Some women may have long cervix also.
You should, less than 2.5, you should start suspecting. This was in a study actually. From 3 centimeter above, the risk was minimal.
Yes.
It shown in the PPT. So after 3 cm, the risk of preterm labor was minimal. There was a slide. So that's why they have given 2.5 to 3. This is ISWOG's.
Yes, but the upper limit does not matter because we're only interested in the short cervix. So you could have a 4.5 centimeters. So what difference does it make? Or a 5.5?
upper limit doesn't. Yes.
Yes, and if there's a previous cesarean section, it can be a very, very long cervix.
Yes.
So we just need a cutoff of 25
Cutoff.
millimeters. Yes.
Yeah. Yes, sir.
So number 9, bilateral
What was
notching.
the job? Number 9.
Bilateral notching in uterine artery is found in how many cases normally? In 11 to 14 weeks of pregnancy, and more than 50% is the right answer, and 38% have given, because bilateral notching will be there because at that point of time in pregnancy, the uterine artery has a musculature which is still there, and it is only because it has a muscle in that arterial level, and the second trophoblastic wave has not yet started. Therefore, we may find notching at this point of time, like 11 to 14 weeks. Thereafter, it should decrease actually. So 50% is the right answer.
And madam, the pre-orientation polls and post-orientation poll results difference is from 30% to 38%, not much difference.
Okay.
ସେଇଟା ଦିଶି ନଥିବ ମ୍ୟାଡାମ, ମଝିରେ ଯୋଉ ସ୍ଲାଇଡ ଗୁଡା ଦିଶିଲାନି, ଆକ୍ଚୁଆଲି ପିଲାମାନଙ୍କୁ ସେଇଠି ପ୍ରୋବ୍ଲେମ ହେଇଥିବ, ଦିଶିଲାନି। ମୁଁ ଭାବୁଛି ମୋ ସ୍ଲାଇଡ ଗୁଡା କେତେ କ୍ଲିୟର ଦିଶିଲାନି।
So now the last question is, tricuspid regurgitation in first trimester is most commonly associated with. I think this is a marker for trisomy 21 because majority of 21 will have TR at that period of time, tricuspid regurgitation. It is a strong marker along with others like ductus, nasal bone. We take all the combined things like absence of nasal bone and tricuspid regurgitation, reversal of ductus. They all point towards trisomy 21. Yeah.
And
What
so the
was the
difference, pre-poll to post-poll, sorry, pre-orientation to post-orientation poll questionnaire difference is from 56% to 67%. Madam.
That
So
means
there
our
was increase.
either our the basic knowledge of our gynecologists are good because it indicates 56%. Okay. So the basic knowledge of our gynecologists, all are good students. They are busy in the actually for the workload, they are not able to read or learn. If they try, definitely they will do wonder after 6 months. And my slide is perfection 100% we could do. And I have shared all my slides to all of your friends in the WhatsApp group right now.
Thank you very much.
I must
One question to
really
Dr. Khurana.
I must
that,
really thank Dr. Khurana. He is always with us, and this encourages us to be prepared. You know,
Yes, sir. क्या बात है, पूछो मत. He
Yes.
always smiles. I don't know from where he brings such smile, good smile.
It is the attendees of the
people are
webinar. They
still
make it
there.
smile. The
For
whole
their
concept-
benefit, I would like to get from Professor Khurana's mouth that this echogenic spot in the cardiac echogenic spot, is it important for detecting trisomy 21?
Yes. So we see whether we have an isolated echogenic intracardiac focus or whether it is associated with other findings. If it is by itself, it has absolutely no relevance for the label of trisomy 21. The risk will remain the same as you calculate otherwise. But if you have associated matters, then this becomes an additional feature. By itself, it is to be ignored completely.
Thank you.
Actually, what is that echogenic cardiac foci? What is the thing actually?
It is a mineralization of the fibers of the papillary muscles. So when the papillary muscles attach to the cardiac wall, this is the area that gets mineralized.
So in which chamber of the heart it is more common?
Changing
The
the
most
gain.
common is in the left ventricle.
Really
Second
left.
most common is in the right ventricle.
Okay, sir. Thank you.
Recently, I saw one in the right ventricle. I changed the gain, and I saw that it was sitting on the moderator bands actually.
It could be, madam. It's not a good.
So it's over mineralization. Somebody who takes a lot of calcium can.
Mineralization. Normally, it is not expected to be mineralized, but you can have an idiopathic mineralization, and it's a very, very common feature in so many fetuses, and by itself does not alter the risk for trisomy 21.
So to detect it has been taken out from the list for.
No,
Not
it's
taken.
such a common feature that we keep putting it on the list. But one day, you see, we haven't revised these criteria. The second trimester criteria have not been revised for many, many years for the simple reason that the developed countries have moved to first trimester screening. We in the Indian context have not yet overcome the late reporting of patients. Patients still feel that the best time to report for a pregnancy to a hospital is 4 to 5 months. And until we overcome that, second trimester markers will remain important for us. But the least important of all of these is the echogenic intracardiac focus. And of course, we should ignore it completely.
Khurana sir, I have one question for you.
Yes.
What is the cause of reverse ductus in aneuploidy? I go through the literature, I went through the literature, and it was
Yes.
the old literature saying that this is due to the improper myocardial contractibility or function of the ventricle, so that the atrium has to contract more to overcome that. That's why it is reversed. Is it the
Yes.
answer, or is there anything for which reason that ductus is reversed?
The pathogenesis remains the same. That is,
Yes.
it is a sign at that stage of a fetal congestive cardiac failure. Just like you have a raised jugular venous pressure in the adult and congestion of the hepatic veins when the patient.
But there is overload. Here there is no overload.
Yes, now here there is no overload, but
No
the
overload,
failure is because of the poor quality of, as they say, contractility of the myocardium.
So I thought
there is no-
that was a very old
The
literature.
second thing, the second thing, there's one more feature that goes with it, and that is the kind of fibrous tissue within the atrioventricular valves. So these are dysplastic valves, and that is why polyvalvular dysplasia is a marker for the aneuploidy.
That could be another. Thank you.
Those also result in regurgitation as well as congestion of the ductus venosus.
Sir, that could also be the connective tissue, also disorganization in the muscle fiber.
That is
Yes,
because
same,
that's the
in
primary.
and it's the same in the heart.
Yeah.
Yeah.
So it was an excellent session. And yeah, your presence is always encouraging us.
makes everyone active.
It's a pleasure, and I'm so glad that everybody is here with such gusto, and we had such a good attendance today.
Priti also has
And
joined.
look
Priti, I
forward
think
to
Priti
every
has joined
Friday.
also.
And my thanks to Dr. Shama Kanungo for putting all this together and for giving me the chance to be a part of this.
It's a chance for us. A chance. It's as if we've got the moon with us. So thank you so much. Everybody waits for this Friday session, all of us, and a lot of learners are very, very happy and very, very grateful also. And I feel it is God's grace. God has arranged everything to have Professor Khurana speaking to our doctors. Actually, they're really, really very fortunate. So are we, all of us. We couldn't have every week to listen to him. Of course, we listen through all other webinars, but our specialists have a scope to see. They will, if they become SFM members. That's why Professor Khurana and our whole team wants all of you to become members of the SFM.
Because that is also
in
very.
that case, you will be able to, in your other time, in the evening hours, there are so many other training sessions going on. If you want to upgrade yourself, even basic things also, if you want to relearn, the scope is there. That's why we.
SFM is a site for refinement. That membership
SFM
will
has so many videos that they can enter and log into and see in the time. And web in the YouTube also there are free videos they can watch, each and every, so many. Even we people don't know anything and we have to visit that, and they should be the member. It is my request. It is not that I am not pursuing you people. You will feel the benefit once you registered yourself as a student.
It is your responsibility now, Jyotsna and Preeti, that you have now central, you've gone to the central committee. It is your bounden duty to see all these specialists become SFM members.
Yes. I
In
need
that
the
case
list
only
for
they
this.
will go, they will increase the fitness in their service and
Yes,
they will
I
enjoy
need the list, madam. Can you please send the list? Then I can personally contact them and ask them. That is the thing. I don't have that list.
No, there is a list. Otherwise, because they are
I don't
contacted.
have that. I don't have that.
ଆପଣ WhatsApp ଗ୍ରୁପ ରେ ସବୁ ନମ୍ବର ଅଛି ନା, ସେଥିରୁ ପାଇ ପାରିବେ ଆପଣ
ଆଚ୍ଛା,
ସବୁ
ଠିକ
ନମ୍ବର
ଅଛି।
ଗୁଡାକ ଅଛି
Okay, I
ଆମର
will connect.
virtual training group ରେ
Yes.
the numbers are there, and of
Okay.
course SFM membership will refine our knowledge. Because there is so much of content. We are having so many webinars, each chapters, then international conferences, we are getting lot of discounts, and we have a very good journal there, and so much to share. I think
And that too with so many minimal amount of fees.
that is the perfect democratic setup which Dr. Khurana sir has set it for everybody. And otherwise, I think without SFM, we would not be learning so much.
Thank you.
And I think I had promised you right in Delhi when we met, I said, yeah, you are doing a wonderful job and I will do all my best to see that it.
You both are pioneers, sir, in the SFM. Okay.
Okay.
Thank you, sir. Thank you, madam. Seema madam, बहुत बहुत धन्यवाद. Jyotsna madam, धन्यवाद. Ajit Babu, you are there. You are to give us all your material long
Yes,
in
next time.
advance. Ajit, Dr. Ajit, you are to share all your slides and MCQs.
Sir, within 2 days I am sending, sir.
Yeah. 6 steps.
I have already
Sambit, I
said.
think some people have added their WhatsApp number in this time also. Are you picking them up?
Yeah, Sambit Babu should add
Yes,
them.
ma'am. I am adding them to this WhatsApp group.
Right,
Each time people want to request, more and more people are requesting to join this group. And Ajit, you see that you ask your HOD that every Friday 3 p.m. you keep this webinar only for the department, so that all
Okay,
can join and you can put it up in the screen there.
Recently, one gynecologist has asked me, what is that, madam? I have asked her to join, and each Friday it is there. She told, I don't know about it, and madam, please send me the link. So I have sent, I think, Hasmukhlal sir's address, phone number.
Is she a state government servant?
Yes.
How
Yes.
come she doesn't know? You
doesn't
give her
know.
number.
She
You
is
give
in
it to Sambit
Dhenkanal.
sir and he
She is
will
in
give it to
Dhenkanal. She told, madam, I don't know. She asked me some queries. So I told it is better to start from the basics, and it is being taught in this group. You attend every day, and last Friday she had attended and texted me, madam, it was really good. I don't remember her name, but I have added in. I have asked, I have sent the link actually her personally.
Yes, Ashwini Vishwanath
I think so.
added a number. So Sambit will be adding the numbers. We can say goodbye to everybody.
Yes, ma'am. Thank you.
Thank you, madam.
Okay, thank you, Ajit.
Ajit, you see
Thanks,
that
ma'am.
all
Thanks, all.
can join the department, okay?
Yes, madam. I will ensure everybody should join, madam. Okay.
Residents, you can have because they can see in their own rooms or anything. You just 3 to 5. Don't keep any other seminars today, Friday.
Okay, madam.
Because
Okay.
to the basic level of training, actually, this is the basic side.
A golden opportunity. Professor Khurana coming to
no one is going to teach you the basics. All the webinar are for the higher level, but basics one should know the only pura grassroots level training. Na? So,
postgraduates, we don't have a class for learning ultrasound. No, they just sit and they just observe and They hardly get the transducers to hold. And if we train them up, we can help more and more patients.
I think this platform, along with simulator and then on site, will really help a lot. And for doing this, you know, it is a very
Sir.
good attempt.
Hasmuklal sir, I have asked Dr. Lakshmi Narayan to contact you. He is ready for on-site as well.
Lakshmi Narayan
Sau, Lakshmi Narayan Sau, fetal medicine, KIMS.
Kims Ray ଅଛନ୍ତି.
ସିଏ ରାଜି ଅଛନ୍ତି on-site ପାଇଁ। ମୁଁ ଭାବିଲି ସେ ଯିବନି ବୋଲି, ସେ କଣ ରାଜି ଅଛନ୍ତି, ମୁଁ କଥା ହଉଥିଲି। ବୋଲେ on-site ପାଇଁ I am interested.
Administration allow କରିବ ତ?
ଆଜ୍ଞା?
ତାଙ୍କ administration allow କରିବ ତାଙ୍କୁ?
ସେଟା ମୁଁ ଜାଣିନି, ସେ କହିଲା ପ୍ରି ନୋଟିସ୍ ହେଲେ ମୁଁ କରିପାରିବି ମ୍ୟାଡାମ, କିଛି ନାହିଁ, I want to go.
AIMS will allow, and those who are private practitioners also, it's on their own option. They will.
ସେମାନେ ସିଏ ତ ମୁଁ ଜାଣିନି, ଆପଣ ତାକୁ କଥା ହେବେ କହିବେ।
Medical college ରେ ଯଦି permission ନ ଦେବେ,
ସେମାନେ ଅଫ୍ ନେବେନି ଯୋଉଦିନ, ସେଦିନ ଆଗରୁ ଛୁଟି କରିକି କରିବେ ଯଦି ଇଣ୍ଟରେଷ୍ଟେଡ। ମୁଁ ଜାଣିନି।
କିମ୍ସ ରେ ଅଛନ୍ତି ନା।
more the merrier, the merrier, the more we have mentors.
ନା on-site ଯିବା ପାଇଁ ଟିକେ କମ ନା, ଯିବା ପାଇଁ ଯଦି କିଏ ରାଜି ଅଛନ୍ତି।
ମ୍ୟାଡାମ ଶୁଣନ୍ତୁ, ମୁଁ ଗୋଟେ କଥା କହିବି ଶ୍ୟାମଳ ମ୍ୟାଡାମ। ହ୍ୟାଲୋ।
ହଁ କୁହ।
ମୁଁ କହୁଛି କଣ, ଆମର ଯୋଉ ମେଡିକାଲ କଲେଜ ମାନଙ୍କରେ on-site training ଦିଆଯାଉଛି MBBS ଡକ୍ଟର ମାନଙ୍କୁ 6 ମାସିଆ, ପ୍ରକୃତରେ actually that କିଛି ସେଟା it is of no use. Actually they are getting PG in some subject and leaving this. So they are not at all doing. So it will be better if you can give at least 1 month hands-on training to the specialist, gynec specialist. That will be better, because all medical colleges now you are giving 6 months training to MBBS doctors. But it is well and good. But those who are doing MBBS and getting medicine PG, getting skin PG, and they are just leaving and they are not doing at all ultrasound. And only those who are getting gynec PG, they are doing the ultrasound. Otherwise, they are just leaving and passing the time for preparation of the PG. So we last 3 years, I have observed in the Kandhamal district, we have sent 9 people, but nobody returned to do the ultrasound. All they have left and they have gone to some other subject. So
Just to be at Cuttack.
So I think it is
you give a proposal. It's a very good proposal, Abhay. You give
Yes.
a proposal, we will ask the MD to
at least
instruct us so
the
that we can
specialists who are not doing or who are not confident in doing ultrasound, because lot of specialists are here. Also we have got specialists at Ballyguda subdivision, we have specialists at headquarters, but they are not confident in doing. Unless they have some hands-on training for 1 month at least, that will be better. I think that will be more useful, because MBBS doctors, they are those who are doing private practice and are interested in ultrasound, it is okay. But those who are the specialists who are MBBS doctor getting PG in medicine, PG in skin, PG in some other subject, SPM, and doing.
Okay, madam.
No, you Abhay, you give the proposal. We will ask the DFW.
Madam, can I leave?
Yes, we are all going to leave. Thank you very much.
Thank you, madam.
Abhay, Hasmukh sir, Professor Khurana has left.
Namaskar.
Right, sir. Namaskar.
Sambit, can we leave? Sambit?
आगे मैडम मु ऐड कर देली जो दी जण डॉक्टर विश्वनाथ और डॉक्टर मोनालिसा देइतले मेसेज मु से मानु ग्रुप रे ऐड कर दी, and now we can end the session.
You can end the meeting from your side.
Yes ma'am, thank you ma'am.
Thank you very much, Sambit.
धन्यवाद.
Thanks,
For the live wire.
Sambit Babu, thank you so much.
Thank you sir आपण मन आशीर्वाद.
Sambit Babu मते पचारिले what is your registration number, and I think when I told him he was surprised, is it?
Yes sir.
He
Sir,
said,
when I used to serve at CSC Kesinga, I used to get your ultrasound reports.
अच्छा. हाँ. Okay. Thank you. धन्यवाद.
Thank you.
Registration number कितने?
मोर registration number 3988.
ओहो.
3988.
Rip Van Winkle. Oh, okay.
Thank you.
Sir,
Thank you, madam. Thank you all.
very much.
Session end coach. Namaskar, madam.
Bye.
Thanks.
Jyotsna.
And thanks to all the
Now you
participants.
give that proposal, right? ଯେମିତି ହେଲେ କରିବା ସେଟା